A very good afternoon to dignitaries, guests, and delegates present here as well as connected through web platform. I feel privileged to extend warm welcome to all for the celebrations of 28th International Conference of Indian Associations of Palliative Care today, organized by AIMS Patna. Since this 28th International Conference falls in COVID era, so same is being organized through virtual conference. The concept of palliative care is relatively new to India, having introduced only in the mid-1980s. Since then, hospice and palliative care services have developed through the efforts of committed individuals, including Indian health professionals as well as volunteers, in collaborations with international organizations and individuals from other countries. IAPCON will improve and expand existing knowledge and skills of individuals working in palliative care, augment the ability to provide professional, competent, and empathetic care to patients and their families, provide an opportunity and platform for informal caregiver to learn about palliative care. Most of you could not to attend the conference, so we are taking to a journey of this venue and our city Patna in a small video clip, which is especially made for you. Please play the video.
Umesh Kumar Badani, Organizing Secretary of IAPCON 2021 Patna, welcome you all. This conference is happening for the first time in Bihar state of India, and Patna is capital of Bihar. We welcome you all from our organizing team. We will have very good topics in our CME and 3 workshops. 1 workshop for nursing staff, 1 workshop for doctors, and 1 for social workers. Nursing workshop is happening in IGIMS Patna. Doctors workshop is happening in AIMS Patna. And for social workers, we are organizing the workshop at Mahavir Cancer Sansthan. I again welcome you. Thank you very much for becoming member of this hybrid and online and offline conference.
A place which may seem like the end may also be the beginning of something new.
P.K. Singh sir on the dais, I feel extremely honored to welcome and introduce the chief guest, who is a visionary man with the extreme focus and clarity of purpose. He is a constant source of inspirations, motivating us all the while in the pursuit for excellence. It is my pleasure to introduce to Director Sir, who is MD in anesthesiology and held contributions in the field of education, PDCC courses and creations of department palliative care in AIMS Patna. Sir, please come on the dais. The next dignitary to honor us with his presence is Dr. R.N. Vishwas sir, Director of IGIMS Patna. It is a great honor to invite Dr. N.R. Vishwas sir on the dais. In few words, I would say that sir has put up lot of efforts for the development of IGIMS Institute. Sir, please come on the dais. The next distinguished to honor us with her presence through web platform is Dr. Sushma Bhatnagar ma'am. We heartily welcome Dr. Sushma Bhatnagar ma'am, President of IAPC. Ma'am, it is your constant support and motivation which has helped us in organizing IAPCON. Though you could not come in the persons to this place, you were just a call away to support us at each level, right from the inceptions of IAPCON Patna till today. Ma'am is the MD anesthesiology professor and head in onco anesthesia, pain and palliative medicine, IRCH, All India Institute of Medical Sciences, New Delhi. Ma'am is also the founder of DM in onco anesthesia and MD in palliative medicine at AIMS Patna. Now I would welcome Dr. Shavita Vatola ma'am. Her involvement in this field has been an example to all of us. Ma'am is the national faculty for IAPCON. Her is interest about creating awareness and educational opportunity for the palliative care. She is also launched first online waiver and support website in India. I would like to invite Dr. UK Badani sir, organizing secretary of the conference and head of the Department of Anesthesia and Dean of the AIMS Patna on the dais. Sir had worked a lot in the field of palliative care. Sir, please come on the dais. I would also welcome and invite Dr. L.B. Singh, Superintendent of Mahavir Cancer Sansthan and Research Center on the dais. I would like to welcome and invite Dr. C.M. Singh sir, Medical Superintendent of AIMS Patna. He is a constant source of inspirations. Sir, please come on the dais. I would also like to invite Dr. Chandni Sinha ma'am, Scientific Secretary of the conference on the dais. Dr. Chandni ma'am is additional professor in the Department of Anesthesia, AIMS Patna. She has worked closely with Dr. Sushma Bhatnagar ma'am and Dr. Shavita ma'am to organize the scientific session of this conference. Now I request to Dr. Dharini to give a token of love to our director, sir. Dr. Surbi to give a flowers to our director sir of Dr. R.N. Vishwas. Dr. Babli to give a flower to UK Badani sir. Dr. Ammo to give a flower to Dr. MS sir. Dr. Arunima to give a flower Dr. L.B. Singh sir. And Dr. Padma to give a flower Dr. Chandi ma'am. Since we have organized IAPCON 2021 in such a difficult situations, we hope that it is would be very successful and fruitful. Now we would like to go ahead for lamp lighting ceremony. For this, I take opportunity to invite our chief guest, our director, sir, Dr. P.K. Singh, sir, and other dignitaries, Dr. R.N. Vishwas, sir, and Dr. L.B. Singh, sir, Dr. C.M. Singh, sir, Dr. Umesh Kumar Bhadani, sir, Dr. Chandni Sinha, ma'am, and all faculties of Department of Anesthesia, and Dr. N.R. Vishwas, sir.
हे हंस वाहिनी ज्ञानदायिनी अम्ब विमल मति दे। हे हंस वाहिनी ज्ञानदायिनी अम्ब विमल मति दे। जग सिर मोर बनाए भारत वह बल विक्रम दे। जग सिर मोर बनाए भारत वह बल विक्रम दे। हे हंस वाहिनी ज्ञानदायिनी अम्ब विमल मति दे। साहसशील हृदय में भर दे जीवन त्याग तपोमय कर दे। साहसशील हृदय में भर दे जीवन त्याग तपोमय कर दे। संयम सत्य स्नेह कवर दे स्वाभिमान भर दे। संयम सत्य स्नेह कवर दे स्वाभिमान भर दे। हे हंस वाहिनी ज्ञानदायिनी अम्ब विमल मति दे। लव कुश ध्रुव प्रहलाद बने हम मानवता का त्रास हरे हम। लव कुश ध्रुव प्रहलाद बने हम मानवता का त्रास हरे हम। सीता सावित्री दुर्गा माँ फिर घर घर भर दे। सीता सावित्री दुर्गा माँ फिर घर घर भर दे। हे हंस वाहिनी ज्ञानदायिनी अम्ब विमल मति दे। अम्ब विमल मति दे। अम्ब विमल मति दे।
We would further continue the program. I would like to invite our Honorable Director, Sir, Dr. P.K. Singh, sir. Sir, please come up on the stage and say few words for our blessings.
Our dignitaries on the dais, Professor N.R. Vishwas, the Director of IGIMS, Head of the Department of Anesthesia, Dr. Bhadani, Medical Superintendent, Dr. C.M. Singh, Organizer, Committee Chairperson, Dr. Chandni Sinha, Dr. L.B. Singh, the invited faculty members here, participants, and all those who are actually attending this conference through online platform. So welcome to the IAPCON, welcome to this inaugural function of the conference. on palliative care, a branch which is dedicated to improving the quality of life in all those patients who have chronic ailments, more focused on the cancer patients, but not limited to. Somehow, that has not been done in our country as far as the palliative care is concerned. And more and more activity is being organized as far as the palliative care is concerned. But if we compare it to the need of the country, perhaps we need more palliative care centers. There are very few. We need more doctors dedicated to the palliative care. We need more paramedical staff who can really contribute into the palliative care services. We need a very defined and structured program for teaching and training to all those who are willing or aspiring to become a palliative care specialist. And these are all the works which actually we have been thinking and we have been doing in parts and bits, but it has not yet come so far in a fully organized form at a country level. These are the tasks which I'm sure in the conference, there will be a debate, there will be discussions on such issues, which are very important. How to spend our palliative care services to meet out the country's need, and how to increase the capacity building, and how to cover everybody who is in need of the palliative care. I'm congratulating the Department of Anesthesia and the organizers for organizing such a wonderful conference and such an important topic. And my best wishes are for everyone, and that certainly the conference and the discussions which are held in the conference will certainly brings out some important decisions in this regard, and there will be exchange of thoughts how we can best provide the palliative care services in our country. Thank you so much.
Thank you, sir. I would request to Dr. R.N. Vishwas, sir, please come up on the stage and say a few words.
I am not R.N. Vishwas. ठीक है. So my apology, I am not R.N. Vishwas, I am N.R. Vishwas. Anyway, thank you for inviting me here. Professor P.K. Singh, Director, Dr. L.B. Singh, Medical Superintendent, Mahavir Cancer Institute, Dr. Singh, Medical Superintendent here, IGMS, Dr. Badani, Dean and Head of Anesthesiology, and Dr. Chandni Sinha, you are also Scientific Secretary, and two more on my colleague, Dr. Sushma Bhatnagar. She is the President and she is online from AIMS, and Secretary IAPC is Dr. Savita Butula. She is also online. Sri Acharya Kishore Kunal was to be present here, but for some urgent work, he is out of station. So I hope his best wishes and blessings also with us. Dr. Rajnish is also treasurer, and all my colleagues who have come from IGMS and all dignitaries, all faculties of AIMS Patna, students. It's really heartening to note that this conference is on virtual mode, and as Dr. Badani told me just now that the online conference will start from 4 p.m. and 4 p.m. to 9 p.m. to adjust the timing of the international faculty. There will be around 400 delegates and from 20 countries. And this is the 28th International Virtual Conference of Indian Association of Palliative Care, starting today, and will continue till 21st March. In fact, palliative care is something, as Dr. Singh told, that this is not restricted only to cancer patients, to all patients. Because man is mortal. We are born and we have to go one day. But that last part of the journey should be smooth, should be pain-free, should be comfortable. And for that, medicine is not enough. You give some morphine, some painkiller, that's not enough. Human touch, that is more important. Empathy, that's why you have kept the theme of the conference is searching empathy through research. That is very important. I saw in the ring road near the AIMS, the Shanti Vedanta Ashram, and I visited sometime there. They treat the last phase of patients. Unfortunately, my daughter was working there for some time, just as a trainee type, and they are doing good job. So we need places like that, where everyone has finished their job. No medicine, no surgery, no radiation oncology is required, but only human touch. Suffering of the last part, that is important. And that's why we need hospice in different places. So I was talking with Dr. Singh just now that we have a plan here to make hospice. If we have land and if we have budget, I think I'll try to make it in IGMS, because that is required for the last cancer patients at the last part of the life, and in that case, other patients also. That's very important. And some other point I want to highlight that the theme, searching empathy through research. Research is also very important component of any treatment, because medical science is a dynamic subject. Every day new thing is coming, every day new modalities, every day with minimum hurt, with minimum suffering treatment, with minimum side effect, so targeted drug delivery, so that there will be no side effect in other part where it is not affected. Nanotechnology. So that's why research should be inculcated, should be encouraged. That should be the motto of institute like this. Teaching, along with patient care, the research, every faculty, every resident should have some time for doing research. That's why I have started, when I joined here, a section of Dean Research following the AIMS New Delhi pattern. And fortunately, yesterday we have an oration in the name of first Dean of IGMS, Dr. P.K. oration. So that people assemble together, discuss about new thing and do good research. And the person I called as an orator was also none less than a very thorough person who is now, after retirement, is working in Netaji Subhash Institute, Dr. Shantanu Tripathi as Dean and Department of Pharmacology as head of the department. Introspection is also important, where we are lacking behind, how we can improve. But there is a complacency, nothing will be there. If you think that I have learned everything, I have nothing to learn, that means your learning process is stopped. And that can be done only through introspection. The research component is also important in all field of the medicine, including the palliative medicine. So I wish best of luck for your endeavor, and it is very good and very encouraging and very informative. And as I was told by Dr. Badani that there will be 400 delegates from 20 countries. So I wish grand success of this conference. Thank you very much, and thank you for calling me.
Thank you, sir. I would like to invite Dr. Sushma Bhatnagar ma'am to say a few words.
So, Professor Singh, Professor Vishwas, all the dignitaries of the dais, Dr. Badani, my dear friend, Janni, I'm really sorry that I'm not there with you today physically, but all the time since morning, I'm just thinking only about this conference, and we together are thinking since last 1 year only about this conference. So last year when we celebrated or we organized this conference as Guwahati and planned this conference at Patna, we were not sure that all this year we will struggle and we will fight so badly. And in the middle of the year, we started thinking that how IAPC can be committed to have an academic activity continued, and we did it. So I really want to congratulate Dr. Badani, Chandni, and the whole team, and Dr. Singh, please, your support. Dr. Vishwas, your support. The way you have done all these four workshops in various places, plus this conference at AIMS Patna during this time, it really needs, we want to give you a huge round of applause. Plus, we want to really congratulate. So on behalf of whole of the community of palliative medicine of India, I really want to congratulate the organizing committee of this conference. They did. This is first virtual conference. Again, we were very apprehensive that whether people will register for this conference, and I was shocked to see more than 450 participants have already registered. We were not sure that we will get the posters, but almost 100 poster abstracts we have received for posters. And because it is online, so we could not allow more than 6 abstracts for oral presentation. So we have a 6 oral presentation. And one more very nice thing has happened in this conference, that journal Journal of Supportive Care has BMJ Supportive and Palliative Care has offered to publish the best paper. Although there will be a lot of there will be full review process, and editor will review the paper, but the abstract and the full paper will be published in BMJ Supportive and Palliative Care. And this offer, we really want to welcome this offer, and we want to thank them that they have offered, and this offer will remain throughout in the subsequent conferences. So at the end, I just want to say, I am with you. I think since morning I have not done anything. I am just thinking of this conference, that everything should go on time and everything should be smooth. There should not be any problem. And I can see that the workshop really has happened well. I was attending the workshop. I have attended few lectures in the nursing workshop. It has gone really well. And I know that all other workshops will also go well. Dr. Badani, you have really worked hard, and we are proud of you. And we used to talk almost every week, every day, Chandni, but Dr. Badani and Rita and Richa, and I think everybody has worked as a team, and they have done wonders. So I'm really happy that in spite of all the odd circumstances, this conference is happening, and I want to congratulate, and I wish it's a grand success. Definitely, this is going to be a grand success, and I want to also thank our supporters, those who have supported this conference financially, because ultimately we were again very apprehensive whether, because it is a virtual nature, whether we will get support from the people or various organizations, but definitely we have received the support from various organizations. This also says that people are there to help and support even and continue the academic activity throughout the country. So I thank you, the palliative care community of whole of India, and also wish a grand success for this conference. Thank you, Professor Singh. Thank you, Dr. Bishwas, and thank you, Chandni, Dr. Badani, for supporting this and giving this conference a full support. And you have kept IAPC's flag up, that in spite of all circumstances, we can continue and we can do it. Thank you very much.
Thank you, ma'am. I would like to play the video composed by Dr. Shavita Vatola, ma'am. Please play the video.
Dear friends, on behalf of the IAPC, I welcome you all to the 28th International Conference. This is the first one being conducted online. One of the many changes which have been brought about as a result of the COVID pandemic. As we are all aware, the last year has been one where the world was forced to take a closer look at life, loss, grief, and healthcare workers. All of us faced unprecedented challenges. We were forced to analyze our own strengths and weaknesses and also to tap into our hidden potentials and go ahead with courage. This year, the early part of this year saw hope in the form of vaccination, which again brought home the fact how important these medical miracles are as a result of the tremendous amount of research, education, and training that goes on behind the scenes. Into our own spheres, we assimilate new learning with new technology in the form of online conferences, meetings, and new methodologies of learning. So, again, I welcome you all. And though we are going to sorely miss meeting all our dear friends face to face, we hope that this will be a fruitful learning experience for all of you. And we look forward to meeting you all physically next year. Thank you.
Good evening, everybody. Our director, sir, Dr. P.K. Singh, the director, IGMS, Dr. N.R. Biswas, medical superintendent, Mahavir Cancer, Dr. L.V. Singh, our superintendent, Dr. C.M. Singh, deputy director, Mr. Parimal Sinha, Dr. Abhijit Dam, past secretary, Indian Association of Palliative Care, Mr. Ganpati, who is from Mumbai all way coming to here, Sister Hanife, a lot of other names are here who are making this conference a success. Actually, we are doing these inaugurations at this time, 2:30 to 3:30, but already our main conference has been started today morning with the nurses workshop. And I'm happy to inform that there were 85 participants for the nurses workshop, which occurred in IGIMS Patna. Another good thing that just now I inquired from the computer people sitting in Delhi that how much was the total registration. I was very fearful that this is online conference. I don't know how much people will register because this is a paid registration. It's not like we are getting a lot of invitation these days for webinars and others which are free. But I feel that when you put some weight in it, it becomes more important. And fortunately, we have got more than 450 registrations till today. And there are about 50 registrations from abroad other than India. So why this timing is 4 p.m. to 9 p.m. Yet we are here in 2:30 or 3:30, but actually this conference is being seen and will be watched in all time zones of the world. This is, you can say, one good thing about this kind of conference. And I call it hybrid because the workshops are offline workshop, because workshop is something which one has to learn by seeing things, by doing your hand. So, and this part of the India, that is Bihar, actually it is one of the most populous states of India, but the palliative care is very much in primitive stage here. This thing, I started doing palliative care thanks to Dr. Cynthia Go from the Singapore. She and Dr. Sushma Bhatnagar wanted 2 doctors and 2 nursing staff from 2 institutes of Patna, our institute and IGIMS, to get trained for palliative care with hospice and care from Singapore. And first we got trained about 3 years ago, and there were 10 aims in which this training was started. And it is a good thing that all 10 centers is now having a very good working palliative care services. Likewise, I want to thank our director, Professor P.K. Singh. He has got a very good concept of palliative care. He not only allowed our OPD for palliative care, but gave us about 18 beds of palliative care indoor. So that is a very big thing at this stage. And after that, from our institute, from IGIMS and Mahavir Cancer Sansthan, we met government of Bihar representative also, so that the palliative care services and morphine should be available each and every part of this state. Unfortunately, till now, morphine is only available in capital city, that is Patna, and that only in these 3 centers. We know there are a lot of legal issues which deals with the storage and prescription of morphine. So our target is that each person who needs palliative care in our state should get it within his or her reach. And this conference is one small step in that, to sensitize ourselves, our colleagues, because people tell that palliative care starts when other treatment raise their hand. Now we cannot do that. But fortunately, the palliative care is one branch where our work start when other people say that now we cannot do much from our medical science. So there is a lot of clinical CMEs, and I must thank Dr. Naveen Salins for his great idea of palliative care through research. So from 4 p.m. to 8 p.m., every day there is one theme, and there are one theme leader and 4 speakers in that session. So today, tomorrow, and day after tomorrow, there are many sessions of 4 speakers with one theme, like theme of pediatric palliative care, theme of adult palliative care, pain, respiratory distress, spirituality, psychological aspects like that. Then another thing I want to inform that we will, to give message to our postgraduate students, we are organizing quiz also. And Mr. Ganpati, Dr. Kahkashan for Muzaffarpur, and Abhyuday from our department, they are taking the lead role of organizing the quiz, in which there will be a fastest finger first round, then other question answer session, one of its kind. And this is also a learning lesson for us. We are preparing for last 1 month, doing lot of dry run and other things. So and this is also one new experience for us, to having a hybrid kind of conference. But this COVID has made us to do so, and this is an opportunity also that we are able to do this kind of conference. There are a lot of things to tell, but another good thing about this kind of conference is that we are bound with time. 2:30 to 3:30 is our inauguration session. Then we will have the real CME starts from 4 p.m. So I have many more words and things to share with you, but I cannot go more. I must thank all the faculties who has come for the workshop from Delhi, from Mumbai. There are a lot of our colleagues, Sachidanand, Nishkars, Anju, all these are, then Sister Hanife and her team, Vijay from Jodhpur, then Sudeep. There are a lot of names who are here to do the workshop. Dr. Abhijit Dam for the doctor's workshop, and whole of our department team, starting from the hospital attendant, our technician, our postgraduate students, they are contributing, and you can see these people are making this thing possible. Thank you, sir, for coming here. And I must give you an assurance that whole 3 day, there will be a very good, both, not only the academic phase, but opportunity to present. And in the website, if you visit, there are poster session, there are commercial stalls, there are session for art exhibition, resource center, and many more things in the soft format. So I will like you to visit those who have registered the website and see the things. Just in the end, I can say कि चला तो था मैं अकेले, मगर लोग मिलते गए और कारवां बनता गया. धन्यवाद.
Thank you, sir. I would request Dr. Chandni Sinha ma'am to say a few words.
A very good afternoon to all of you, and a big namaste to everybody. Firstly, thank you for entrusting me with this huge responsibility of so-called scientific coordinator. I say huge because all of us know that organizing such a big academic event on a virtual platform is not easy. Firstly, I would like to thank Dr. Shishma Bhatnagar ma'am, HOD IRCH and President of IAPC, and Dr. Savita Batola ma'am, Secretary IAPC, who thought Firstly, that this conference is possible, and secondly, that I could be the scientific coordinator. The main challenge was not only including all the relevant topics, but also managing international time zones. Believe me, it's not an easy task, but as we know, teamwork is the key to success. Hence, first, I would like to thank my team members, Dr. Abhyuday and Dr. Pavan, for their unconditional support and untiring efforts throughout the preparation. So we start off the virtual session from 4 p.m. to 9 p.m. today. This goes on till 21st of March. Each hour has a specific theme, being moderated by a theme leader, and has 4 speakers to speak about the relevant topics, followed by a panel discussion. In the morning, we finish the nursing workshop, but would be having workshops for doctor tomorrow and social workers the day after. We are also excited to host an online quiz with participants from all over the country. The virtual platform might not be exciting in terms of so-called conference, wherein we get to meet people and interact in person. But the greatest advantage is that we have experts from all over the world talking from their comfort zones. And I feel this adds to a greater output of dissemination and assimilation of knowledge. Finally, I believe that a good conference is mostly about good scientific content. We have tried to put in our best speakers with best possible topics in best possible time slots. I'm also glad that we've had so many registrations, which has only encouraged us further. I sincerely hope that you enjoy this academic feast to its fullest, and I would be satisfied at the end of it that the job has been done well. Thank you once again to all the team leaders, faculties, delegates, and finally my teammates. Hope you all enjoy the conference. Thank you.
Thank you, ma'am. I would like to invite Dr. L.B. Singh sir to say a few words.
Before he speak, I will like to say thank you to Achar Kishore Kunal, who promised that he will be today here, but due to his prior engagement, he is in Ayodhya. But Dr. L.V. Singh agreed to come and say his message also and his plan for the whole palliative care from his team from Mahavir Cancer Sansthan. Dr. L.V. Singh, please, sir.
थैंक यू डॉक्टर बदानी। इस महत्वपूर्ण कॉन्फ्रेंस में सम्मानित अतिथिगण, डॉक्टर पीके सिंह साहब डायरेक्टर हैं होस्ट इंस्टीट्यूट के, एंड वी आर प्राउड ऑफ यू सर। डॉक्टर एनआर विश्वास साहब, हम बहुत क्लोज हैं हम लोगों से, और ये IJMS को जिन्होंने शेप दिया है, यू कैन नॉट बिलीव जो व्हाट वाज द शेप before he's coming to IJMS, and after his arrival things changed, and I think the special extension was given. I was present in that meeting when CM he was explaining everything, his term was going to lapse. There CM himself told that Biswas sahab aapke liye hum log कानून में बदलाव लाएंगे, and Dr. N.R. Biswas has come up to the expectation of the government, and IJMS has become a center of excellence for treatment. और हमारे जो डॉक्टर आचार्य किशोर कुणाल साहब, जो हम लोग के अभिभावक हैं, महावीर मंदिर न्यास समिति के ट्रस्ट के सचिव हैं, उन्होंने जो महावीर कैंसर संस्थान बनाया है, उनका विजन था 18 साल पहले उन्होंने विजन लिया कैंसर से बनाएंगे, दैट वाज ग्रेट चैलेंज। लोगों ने बहुत डिस्करेज किया, जो मन नहीं चलेगा, लेकिन उनकी कमिटमेंट और उनका फार साइटेडनेस से आज कैंसर महावीर कैंसर संस्थान कंट्री में एक पोजीशन रखता है। आज हम लोगों के पास 650 बेड है कैंसर पेशेंट्स का, एंड वी हैव ह्यूज नंबर ऑफ कैंसर पेशेंट्स। अगर आप जाएंगे तो वहाँ पर 99.9% वेरी वेरी पुअर पेशेंट्स, वी आर कैटरिंग दोज ग्रुप ऑफ पेशेंट्स। और हमारे जो अतिथि और हैं, सब दोस्त हैं, डॉक्टर भदानी, डॉक्टर CM सिंह सालिनी जी, और ये जो एम्स के फैकल्टी हैं सारे लोग, प्लस हमारे महावीर कैंसर संस्थान की भी जो महिला ग्रुप आगे में बैठी हुई रीता टीम, और जो भी यहाँ इस सभागार में प्रेजेंट हैं, और डॉक्टर सुषमा भटनागर जी जो वर्चुअल रूप से हम लोग के साथ जुड़े हुए हैं, डॉक्टर सविता बुटानी, आप सबों का इस महत्वपूर्ण कॉन्फ्रेंस में बहुत बहुत अभिवादन है। ये बहुत ही महत्वपूर्ण है। जो सीरियस मरीज जो भी हों, नेचुरली कैंसर एक ऐसा शब्द है जो जब भी कैंसर वर्ड आता है तो लोग समझता है जो हम मरेंगे ही, डेथ इज डेस्टाइंड, लोगों में ये फीलिंग है डेथ डेस्टाइंड है, इसलिए उनका क्वालिटी ऑफ लाइफ व्हेन डायग्नोसिस इज मेड वहीं से लाइफ डिटोरिएट कर जाता है। उनको एक बहुत बड़ा एक सबल बहुत बड़ा सपोर्ट की जरूरत होती है। They need support, they need support from the medical team, from the society, from the family. तो वहां पर एक बहुत बड़ा सपोर्ट सिस्टम, although this is applicable for all the serious cases, सारे चीज के लिए applicable है, लेकिन कैंसर पेशेंट के लिए बहुत ही जरूरी है जो सपोर्ट उसको मिले, उसको गुड वर्ड्स मिले। I am quoting one example, few years back, 20 years back, when I was in Kurji Holy Family Hospital as a physician, एक बाबा थे, very old man, बहुत रिच पर्सन थे, लेकिन he was too old, तो नर्सिंग वहाँ का काफी अच्छा था। नर्सेस लोग उनका नाखून बनाने से लेके बाल झाड़ने से लेके सब कुछ कर रही थी। तो जब डिस्चार्ज हो गए बाबा को जब डिस्चार्ज हम लोगों ने किया तो रोने लगे। हम के सब डिस्चार्ज होते समय खुश होता है, तो आप डिस्चार्ज होने के समय में क्यों रो रहे हैं? नहीं डॉक्टर साहब, हम रहना चाहेंगे, क्योंकि ये बच्चियां जो सेवा की है, he was indicating to the nurses, ये जो सेवा की है हमारे ग्रैंड चिल्ड्रन बेटी बेटा कोई नहीं करता है, इसलिए आज हम अपना प्रॉपर्टी बेच कर भी इन लोगों को दें, आई विल बी मोर सेटिस्फाइड। तो ये ग्रेटिफाइंग चीज है। अगर आप पेशेंट को देखते हैं, अच्छे से बात करते हैं, तो उसका जो एक रिस्पॉन्स होता है बहुत इंपॉर्टेंट चीज है। आजकल के टाइम में अभी जो मॉडर्न मेडिसिन में है, जो ये बहुत चीज आगे है, मशीन से ज्यादा ये इंटरेक्शन होता है विद द पेशेंट, बट द ह्यूमन टच दैट व्हिच प्रिवेल्स, दैट इज द मोस्ट इंपॉर्टेंट। आप मरीज से अच्छा से बात कीजिएगा तो उसको जो हीलिंग टच होगा दैट विल ओवर सभी मेडिसिन से बड़ा है। अगर आप उनसे अच्छे से बात कर लीजिए, दैट इज द बेस्ट क्योर फॉर हिम। एक्टिव ट्रीटमेंट तो जरूरी है ही, साथ साथ ये पैलिएटिव केयर का जो हुआ है यह बहुत ही महत्वपूर्ण चीज है। 2 साल पहले की मैं बात बता रहा हूँ, मैं अमेरिका गया हुआ था, वहाँ पैलिएटिव केयर सेंटर देखने का मौका मिला। आई वॉज सो इम्प्रेस्ड, जो कितने वो लोग खुश हैं, दे मोस्ट ऑफ देम आर डाइंग पेशेंट, लेकिन उनका क्वालिटी ऑफ लाइफ इतना बढ़िया बनाया गया है, इट इज बियॉन्ड इमेजिनेशन। तो जब हम यहाँ आए पटना में, डॉक्टर ईता रानी हैं, यहाँ पर भी हम लोग के यहाँ पैलिएटिव केयर का काम चल रहा है, और तभी हम लोगों ने निर्णय किया कि एक पैलिएटिव केयर हॉस्पिटल बनावे। ऑल्दो हम लोग तो पीके सिंह साहब या विश्वास साहब जैसा रिच नहीं है, कुछ नहीं है, बहुत बड़ा सपोर्ट है इन लोगों को सरकार का, हम लोग तो सेल्फ जनरेट करते हैं। तो उसमें हम लोगों ने एक पैलिएटिव केयर बनाने का प्रण लिया, 100 बेडेड हॉस्पिटल, पैलिएटिव केयर हॉस्पिटल का। और जो आप यहाँ एम्स से हार्डली 3 किलोमीटर है, टुवर्ड्स फुलवारी शरीफ मेन रोड पर है। तो हम लोग ये चाह रहे हैं जो 100 बेड का पैलिएटिव केयर हॉस्पिटल बनाए। कुणाल साहब भी कहता है डॉक्टर साहब जैसे हो इसको बनवाइए, तो हम लोग जैसे होगा, कोरोना के चलते प्रॉब्लम हुआ, नहीं तो हम लोग उसको बना लिए रहते। लेकिन वेरी शॉर्टली वी आर गोइंग टू स्टार्ट वर्क फॉर दिस पैलिएटिव केयर हॉस्पिटल, दैट विल बी ए ग्रेट रिलीफ टू द डाइंग पेशेंट। 3 चीज है जो डॉक्टर्स इसमें हैं, जो सर आप लोग एम्स है, एएमएस आज का कॉन्फ्रेंस है, दैट इज डेडिकेटेड टू मोस्टली डॉक्टर्स कम्युनिटी में नंबर 1 पे। तो आप तो थिंक टैंक है, यू आर थिंक टैंक, आप जो समझेंगे उसको नीचे भेजेंगे। नीचे में कौन है? कम्युनिटी है, जो नर्सेस है, जो सोशल वर्कर्स है, तो उनके लिए ट्रेनिंग बहुत जरूरी है, व्हिच यू आर गोइंग टू डू, दैट इज वेरी इंपॉर्टेंट। तो जो आप लोग थिंक टैंक है मेडिकल साइंस के, उसको रिमोट पेरिफेरी तक जाना बहुत जरूरी है, जिसमें कि सोशल वर्कर्स का एक्टिविटी बहुत ही जरूरी है। इसमें सर मैं एक बात कहना चाहूंगा, जो क्वैक वर्ड होता है, सब लोग जानते हैं, जो बिहार नहीं हिंदुस्तान भर में क्वैक्स भरे हुए हैं, नो क्वैक्स अब वही प्रोहिबिटेड है, आप क्वैक्स नहीं कर सकते हैं माननीय राजस्थान हाईकोर्ट के निर्णय अनुसार। तो मान लीजिए स्वास्थ्य कर्मी, तो जो ग्रामीण स्वास्थ्य कर्मी है, यहाँ हमने मुख्यमंत्री जी को एक प्रपोजल दिया था, तो उनको कौशल विकास करने के लिए, तो सारा डिटेल्स देने के बाद 1 ईयर का हम लोगों ने विथ इन गवर्नमेंट हॉस्पिटल्स जितने भी थे उन लोगों का कम्युनिटी हेल्थ वर्कर के रूप में ट्रेनिंग दिया गया है इन गवर्नमेंट हॉस्पिटल्स 1 साल का। इन लोगों को अगर इस प्रोग्राम में जोड़ा जाए, भदानी साहब आपको शायद मैं पहले मेंशन किया था, आपको जितना वर्कर्स चाहिए आई विल गिव यू, जो आपके मिशन को पेरीफेरी तक पहुंचावे। इसमें पेरीफेरी से लोगों को जोड़ना बहुत जरूरी है। बहुत इंपॉर्टेंट कॉन्फ्रेंस है, टाइम नहीं है। और हम लोग चाहते हैं महावीर कैंसर संस्थान की तरफ से, आचार्य किशोर की तरफ से यह जो प्रयास है एम्स का, भदानी साहब का बहुत ही कर्मठ व्यक्ति हैं, सबसे मिलजुल के काम कराते रहते हैं, तो इस बहुत ही सक्सेसफुल हो, एंड दैट विल बी अ माइलस्टोन इन पैलिएटिव केयर ट्रीटमेंट इन बिहार एज वेल इंडिया एज वेल इन इंटायर वर्ल्ड। थैंक यू वेरी मच।
Thank you, sir. I would like to invite Dr. CM Singh, sir, to say a few words.
Honorable Director, sir, Professor P.K. Singh, sir, Honorable Director of IGMS, Professor N.R. Biswas, sahab, Dean AIIMS Patna, Professor Umesh Badani, sahab, Dr. L.B. Singh, Medical Superintendent, Mahavir Cancer Institute, Dr. Chandni, Scientific Secretary, you can say Scientific Chairman of this conference, President and Secretary of 28th IAPCON 2021. Very good afternoon to all of you, faculty members of different department of AIIMS Patna, and delegates, nursing officers, and dear friend. A very good afternoon to all of you. Most of thing has been told by expert about the palliative care. We know how palliative care is important in this time, or in any time you can say. This is not restricted to only cancer patient, but it is required to COPD patient, heart patient, or so many patient at the terminal stage, you can say. But what when I was seeing, as Professor Badani told, that it is at very primitive stage in state of Bihar. But what I was seeing a report of WHO in which it was reported like at this time 40 million of peoples are need of palliative care services. Out of these 40 million peoples, 78% peoples belong to low and middle income country, and out of these 78 people, only 14% of people are getting the palliative care services all over India. If the things are in such primitive stage in world, we can see, we can perceive how it will be in a state like Bihar. So there is a need of developing the palliative care in this part of world, in India. And for this, I will request to President and Secretary of Association, put the things to governments for making the policy, program, generating the resources, and training the peoples, training the doctors, training the nurses, training the other paramedics staff for helping in providing the palliative care services. For this conference, I would like to congratulate the department for taking the initiative of organizing a such important conference, and I am confident that they will do the justice for this. Thank you. Thank you so much.
Thank you, sir. I would like to invite Dr. Rajneesh, Treasurer of IAPCON and Associate Professor, Department of Anesthesia, to say a few words.
First of all, good afternoon to everyone. Respected Director, sir, Dr. P.K. Singh, sir, respected Professor Dr. N.R. Biswas, sir, Director IGMS, Professor Dr. Umesh Kumar Badani, sir, HOD Anesthesia, Professor Dr. C.M. Singh, sir, Medical Superintendent, AIIMS Patna, and Medical Superintendent, Mahavir Cancer Sansthan, Dr. L.B. Singh, sir, and respected my seniors, my colleague. I thanks all of you for coming here. On behalf of IAPCON team, I welcome all the delegates and dignitaries in hybrid conference and online hybrid workshop and online conference on this auspicious day. This is the first time we are organizing hybrid workshop and online conference. By virtue of this online conference, we will able to connect to prominent faculties from different part of the world. I thanks Professor Umesh Kumar Vadani sir for giving me opportunity or as a responsibility as a treasurer or as a registration in charge. I thanks Professor P.K. Singh sir for opening palliative care separate 18-bed wards in AIIMS Patna. I thanks Professor N.R. Biswas sir. They have improved IGMS a lot, and they have opened separate palliative care clinic and palliative care ward in the IGMS Patna. I thanks Dr. Professor Susma Bhatnagar ma'am and Dr. Seema ma'am. When I passed MD anesthesia, I joined as a senior resident in AIIMS Delhi. At that time, I don't know about the palliative care. I have nothing about the palliative. What is palliative care? She taught me a lot during senior residency period. And here is Sister Govindi, sister is here, and Sister Nilima, sister is here. So she know how we work during my senior residency. I learned a lot during senior residency period about the palliative care, and during that period, I learned that Dr. Susma ma'am or Dr. Seema ma'am, यदि किसी पेशेंट से बात करने लगती थी तो एक घंटा तक बात करने लगती थी. तो हमें लगता था कि इतना समय क्यों लगता है, क्योंकि हमें ड्यूरिंग एमडी एनेस्थीसिया में तो हम लोग उतना ज्यादा समय नहीं देते थे पैलिएटिव केयर के बारे में कुछ even in our pre-operative evaluation. So मैडम डेढ़ घंटा एक पेशेंट के बारे में बातचीत करती थी. तो पेशेंट सेज कि मैडम कम से कम आप डेली विजिट करने के लिए आइए, कम से कम डेली मिलने के लिए आइए. तो ये है कि यदि हम लोग पेशेंट से मिलते हैं तो many parts, their problems solved in part of palliative care. Okay, so I wish for the success of workshop and conference and for the fruitful for all the delegates. Thank you.
Thank you, sir. I would like to invite Dr. Nishant Sahai, sir, Additional Professor, Department of Anesthesia.
Thank you, and a very good afternoon to everyone. All the respected dignitaries on the dais and all the respected dignitaries who are able to see us online, all the faculty members who have come from outside Patna, and all the faculty members who are from the institute, all the delegates and dear friends. And it is an absolute privilege and a proud privilege for all of us here to be able to participate and coordinate in organization of this big national conference on palliative care. I was given I've been entrusted with the job of looking after the doctor's workshop, for which I would like to thank Badani sir. And as our respected director sir has mentioned, that palliative care is focused on cancer, but not limited to cancer. And our doctor's workshop actually epitomizes quite a bit of that, because we'll be having, in the doctor's workshop, we'll be having sessions on spirituality and communication, as Dr. Rajneesh sir has also mentioned that the importance of communication, as was highlighted by Dr. Sushma's long sessions with the patients. The best part is that we have such eminent faculty from outside who do such exceptional work. Dr. Abhijit Dam sir is here, who actually does this work, and it will be very useful for all the delegates to participate. Communication and spirituality will not only help in palliative care, it will help us in the long run also. After that, we'll be having sessions on pain and breathlessness. And for that, we have eminent speakers from AIIMS New Delhi, the place which does all this work very well. And Dr. Sachidanand sir, Dr. Sachidanandji Bharti, Dr. Nishkash, Dr. Anju, they'll be coming from AIIMS Delhi. They've kindly consented to take all the effort to come from AIMS Delhi, and they'll be explaining all the nuances of palliative care. Apart from that, I'd like to thank our local team. Dr. Sarfaraz has been very helpful, Dr. Ajit, Dr. Amarjeet, all of us. It is a team effort, and I hope all the delegates benefit from our efforts. Thank you so much.
Thank you, sir. I want to introduce Dr. Priya Kulkarni. She is a consultant of palliative medicine, Pune. She is the founder of ACE and Supports India. Ma'am wrote a book titled Touching Hearts Gently, which is going to release here. I would like to play the video, which is composed by ma'am. Please play the video.
Hello everyone, I am Dr. Priyadarshini Kulkarni from Pune. As a past secretary of Indian Association of Palliative Care, I congratulate Dr. Sushma, Dr. Badani and IAPCON 21 team for organizing this conference. The reason why I am talking to you all here is to let you know about my recently published book, Touching Hearts Gently. It's a book which has stories from real life about patients, family members, and well, it also talks about our role in their crucial times. It explains the role of palliative care in different situations and how it can help in making different difficult decisions. I hope you would all go through it and in turn let it know to your patients and families. Once again, I wish all the best to the team IAPCON 21. Thank you.
Now I would request to Director Sir for book release.
Touching Hearts Gently, it is the name of the book, Stories of Compassion, Comfort and Connections Beyond Medicines. It is available in Amazon also, and I have brought here 10 pieces. Anybody can see, and we are giving this book as a prize also in quiz and other events. So this is one, and this is short stories regarding palliative care. Anybody can get this book, 400 rupees. And the authors themselves has published this book, Dr. Priya Kulkarni, and she wanted to take this occasion to release this book. And so I will like all of you can get this book through Amazon or in hard copy also. If anybody wants, they can contact me. I can give them the books. Thank you. Dr. Priyadarshini Kulkarni. Dr. Priyadarshini Kulkarni, Touching Hearts Gently. I will keep these books here during tea time. You can see these books, and anybody can contact me for the hard copy of the books.
Now we will appreciate our guest of honor with mementos. I would like to invite Dr. UK Badani sir, Dr. Rajneesh sir to felicitate our director sir. I would like to invite Director Sir to facilitate to Dr. N.R. Vishwas Sir. I would like to invite our Director Sir to facilitate our Dean Sir, Dr. U.K. Badani Sir. Director Sir. I would like to invite Dr. Badani Sir to facilitate to CM Singh Sir. CM Singh Sir. जी. हाँ. I would like to invite Badani Sir to felicitate to LB Singh Sir. Felicitate. I would call upon Dr. Shagufta, Associate Professor, Department of Anesthesia, on the stage to give vote of thanks to our honorable dignitaries.
A very good afternoon to all. It is my pleasure to be here to give vote of thanks for this event to all the dignitaries present over here, as well as those who have connected virtually. I would like to thank our chief guest and patron, Dr. P.K. Singh Sir, who honored this function with his presence. Sir, you are our source of inspiration and the leading light of the Institute. I also extend my gratitude to our other patrons, Dr. N.R. Biswas, Director IGMS Patna, and Acharya Kishore Kunal's Secretary Sri Mahavir Nyaya Samiti for constantly supporting us in the organization of the conference. I would like to thank Dr. Sushma Bhatnagar ma'am, President IAPC, who is the standing pillar of IAPC and IAPCON. I also thank Dr. Savita Batola ma'am, Secretary IAPC, for guiding us constantly in organizing the conference. I express my sincere gratitude to the Dean and Head of the Department, Dr. U.K. Badani sir, who is our organizing secretary, to make this event a reality by his tireless efforts. I express my heartfelt thanks to MS AIMS Patna, Dr. CM Singh sir, and MS Mahavir Cancer Institute, Dr. LB Singh sir, for coming and blessing us on the occasion. I am grateful to our scientific secretary, Dr. Chandni Sinha, our treasurer, Dr. Rajneesh, and our workshop coordinator, Dr. Nishant, who have worked hard day and night for the success of the event that is going to be started. I also thank Dr. Abhyuday, Dr. Neeraj, Dr. Poonam, Dr. Sarfaraz, and our residents. I feel lucky to be a part of such a cooperative team. I am thankful to all other colleagues in the department who have been striving hard in the organization of a fruitful academic feast. My heartfelt thanks to the heads and faculties of various departments for their encouragement in all our efforts. I thank Dr. Rita Rani for her efforts in organizing the workshop in Cancer Mahavir. My sincere thanks to all the guest faculties who have spared their time and in order to make the conference successful. I would like to thank the audio-visual team for playing a crucial role in the relay of the virtual conference. I thank all the participants, volunteers, and audiences for making this function a grand success. I could have missed a few names, but my thank you goes to all of you. Once again, I thank one and all present over here. Thank you.
With this, I announce the closing of this session, and you all are invited to have a high tea outside this left door exit. And after that, there is another inauguration also with courtesy of Dr. Sanjeev and his team. Sir, please.
I want to welcome a heartiest welcome to the 28th International Conference on Palliative Care by Indian Association of Palliative Care, IAPCON 2021. The theme of IAPCON 2021 is Searching Empathy Through Research. AIIMS Patna takes pride and feels privileged to host this conference. There will be multiple themes discussed in the conference, the first being pain. And the theme leader for this theme, the first theme is pain, and the theme leader for this session is Dr. Shushma Bhatnagar, a very dynamic lady and the driving force behind IAPCON 2021. Madam is Professor and Head Onco Anesthesia, Pain and Palliative Medicine, IRCH AIIMS New Delhi. She is the founder of Cancer Treatment Center Pain Project for Pain Free India. She is President, Indian Association of Palliative Care since 2018 and Chief Editor of Indian Journal of Palliative Care since 2009. I hand over the mic to Madam Shushma Madam for conducting the session. Thank you, ma'am.
Raja, good morning. So please share, allow Dr. Raja to share his screen.
Yes.
So good evening, everyone. Welcome once again. First of all, thank you, Naveen, for designing this program and this conference. As we say that the theme is searching empathy through research, and all the session are based on the themes. First theme is pain, and I'm very happy and honored to announce that the theme of pain. There are three eminent speakers from the world. The first speaker is Dr. Srinivas Raja, the great academician, and I'm very happy and honored once again to say that Dr. Raja has done his MBBS from Patna Medical College in 1974, and afterwards what he has done, when we will all listen, then we will be amazed that the way he has worked hard and achieved so many achievements. I will read one by one. First of all, he did his anesthesiology from University of Washington in 1979. From 1998 to 2006, he was editor of anesthesiology, and 2012 to 2014, he was section editor of pain. He has more than 200 peer-reviewed research publications and editors of 5 textbooks of pain. We all read these books and refer these papers in various manuscripts of ours. In 2014, I still remember, he was chair of Scientific Program Committee of 15th World Congress on Pain. From 2014 to 2016, he was chair for NUC and secretary of International Association of Study of Pain. 2015, he was member US Federal Pain Research Strategy Steering Committee. And now listen, please. The award which he has received, all dream for those awards. In 2010, he received Wilbert E. Fortis Clinical Investigator Award by American Pain Society. In 2010, he received John J. Bonica Award by American Society of Regional Anesthesia and Pain Medicine. And in 2021, John J. Bonica Distinguished Lecture Award by from IASP World Congress on Pain. And today, Dr. Raja, we have read all our residents and all the young pain physician of this country have read the new definition of pain, and Dr. Raja will speak what is new definition by IASP on pain. Dr. Raja, please go ahead. Thank you very much. And we are really, really honored to have you over here.
Thank you very much, Dr. Bhatnagar, for the kind introduction. And thank you for inviting me to participate in this conference. It's particularly gratifying to see that this meeting or conference is being organized in Patna because it brings back youthful memories of my days in Patna Medical College more than 45 years ago. These are my financial disclosures, none of which will be relevant to this presentation. So pain relief is integral to palliative care, and the WHO has defined palliative care as an approach that improves the quality of life of patients and their families. And one of the important goals of this is to prevent and relieve suffering through early identification, correct assessment, and treatment of pain and other problems. So as you can see, pain relief is a very integral part of palliative care. And in fact, the WHO has suggested and recommended that instead of pain relief coming as end of life in oncological care, it should be part and parcel and should be initiated at the very beginning of therapy for the cancer. And this is consistent with the goals of the International Association for the Study of Pain, whose mission is working together for pain relief. So in the vision of the founding fathers of the International Association of the Study of Pain, Dr. John Bonica, the founding father, early on in the 1970s, one of his primary objectives was to develop and adopt universally accepted definitions and terms. And he set up a subcommittee on taxonomy to be headed by Professor Harold Mirsky. And after a couple of years of working on this with a task force, Dr. Mirsky came up and his group came up with this definition of pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. And this definition has been universally accepted, including by the World Health Organization. So in last September, more than 40 years after the original definition, a revised International Association for the Study of Pain definition was published in Pain. And there has been significant media coverage of this definition and claiming that there's some important aspects of this definition to include those who were once left out. So why and what prompted this revised ISP definition of pain? So over the last decade or so, what I would like to do in the next 10 or so minutes is to describe what initiated the conversation for updating the definition. How did we go about in the task force? What was the process adopted? And what were the final recommendations of the task force in terms of revising the definition? And what do we perceive as the potential benefits for patient care and research? So the criticisms of the prior definition and the accompanying notes were that the term unpleasant in the definition trivializes severe pain and suffering, that many patients may have pain that is much more severe, and the word unpleasant does not adequately cover those pain states. Another argument made was it does not address pain in disempowered and neglected populations such as the neonates and the elderly, and that the word described emphasizes verbal self-report at the expense of other nonverbal behaviors that we see in infants or in animals or cognitively impaired humans. But it also ignores mind-body interactions and doesn't highlight the cognitive and social factors in pain experience. And that pain is more than a symptom, that chronic pain is a disease by itself. So these were some of the criticisms that have come up over the last decade or so. So the ISP president, the past president, Judith Turner, and her subsequent president of the ISP, Lars Arne Nielsen, created a task force early, about more than 2 years ago. And this 14-member task force was an international task force that consisted of both basic scientists and members that across disciplines in the pain field to come up to at least examine whether the definition needed to be revised. The methods adopted by the task force included modified Delphi surveys. We had monthly virtual meetings, email discussions, as well as face-to-face discussions. And finally, we also received feedback from the community. Initially, the task force was asked 5 questions. 1, did the definition needed revision? Did the term unpleasant actually, does it trivialize pain? Should cognitive and social aspects be included in the initial definition? And these 5 questions when asked, and whether the notes needed to be changed. As you can see, the task force were almost divided 50-50, except for the fact they all agreed, almost all, that the notes needed to be changed. So we had to make a significant process. There was this considerable discussion regarding whether there was a need for revision of the original definition. The process adapted included, after discussions for almost a year, an initial recommendation, subsequently external consultants, including psychologists, philosophers, and linguists from Oxford as well as Princeton were consulted. And then feedback from both the ISP broader community as well as patients were obtained. And these feedback were subsequently analyzed. A revision was recommended and subsequently voted by the ISP Council, and a manuscript was then published last year. So some of the initial concepts that the task force agreed upon, that definition should be valid for both acute as well as chronic pain, that it should apply to all the pain conditions regardless of the pathophysiology, such as nociceptive pain, neuropathic pain, as well as nociplastic pains. And because the ISP included both individuals treating patients as well as those researching on experimental animals, it should be applicable to non-human animals as well. And we had significant discussions on who should it be focused on. Should it be on the perspective of a person observing a patient with pain, or the individual who's experiencing pain? And the majority decision was it should be on the person experiencing the pain, and that the note should emphasize complex aspects of pain, which would be difficult to describe in a one line or a brief definition. So the initial recommendation by the task force was a definition which included an aversive sensory and emotional experience typically caused by or resembling that caused by actual or potential tissue injury. We added 6 bulleted notes and included an etymology so that one would have an understanding of where the term pain initiated from. This was posted at an ISP website for 1 month, and it was open for comments from both the ISP community as well as the broader population. And we received more than 1,000 comments from individuals in 52 countries, and about 40% were from those in the pain field, and another 40% from pain patients as well as their care providers. And these comments were on 4 broad categories: that we need to make the definition simple and easy to understand, that it needs to better capture the lived experience of pain, and that needs to acknowledge the complexity of the pain experience, and there should be less emphasis on tissue injury. And so these feedback obtained from the broader population was taken into further considerations. And there were significant discussions about the emphasis of tissue injury. And because although it plays a role in nociceptive pain, neuropathic pain as well as nociplastic pain states, pain may be felt in areas where there is no clear tissue damage. And that for example, in knee osteoarthritis, the relationship between pain and the state of the tissue, such as using X-rays or the Kellegren scale, that this was the tissue injury or the degree of tissue injury doesn't directly correlate with pain. And in states such as nociplastic pain states, tissue injury seems to play no proven role. So we wanted to downplay our earlier definition in terms of how tissue injury comes into the definition. So the final recommendations after significant further discussions was a definition which we published, that pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Considerable work was done on the notes section. And the first aspect of the note was that pain is a personal experience. The individual aspect of the pain experience we wanted to highlight, and the fact that it is influenced to varying degrees by biological, psychological, and social factors. So what we've learned over the years that the pain experience is a sum total of these biological, psychological, and social factors. That clearly pain and nociception are different phenomena, that pain cannot be just inferred from activity in the sensory neurons. And therefore, pain is more than just activity along the pain pathways. That through the life experiences, individuals learn the concept of pain, as shown by this art by an 18-year-old suffering from chronic migraine. And this is how her experience of pain is depicted. Further, in the notes, we highlighted that a person's report of an experience of pain as pain should be respected. We wanted to focus that pain, acute pain, while it may serve an adaptive role, persistent or chronic pain may have adverse effects on function and social as well as psychological well-being. And finally, the verbal description is one of several behaviors to express pain, and that inability to communicate does not negate the possibility that a human or a non-human animal experiences pain. So we wanted to make sure that we include infants with pain as well as non-human animals with pain. And the task force recognized that while we have made changes to the original definition, which was more than 40 years ago, that this is a dynamic process that, as said by David Morris, scientific and medical definitions are tools, even when we recognize them as imperfect or provisional, awaiting replacement by an improved version. They perform work that cannot be accomplished by less precise instruments. So what the task force hopes that recognizing pain is an important health condition, that the new definition would help in this process, that it would shift the focus on patients' experiences of their pain, allowing doctors to recognize and believe what they cannot always physically measure using numerical scales. That the definition and the notes demonstrates the complexity and the individuality of the pain, that the pain is an individual and personal experience. It enables the physicians to adequately account for pain in disempowered and neglected populations, such as children, elderly, and people with disabilities. And we hope that it recognizes the multidimensionality of pain, especially chronic pain, and emphasizes the need for multidisciplinary care. And one of our hopes is that this will be adopted by multiple organizations and will help in patients getting improved healthcare and adopted by insurance providers as well. Again, as you can see from the 1979 definition to the present one, the original definition has not been changed dramatically, and this reflects the wisdom of our prior Professor Mirsky and their group. And the major changes have been in the notes, which have been more bulleted, and significant changes have been made to that. Thank you very much.
Thank you, Professor Raja. I think such a wonderful definition you have given to the world. And now people will realize that pain management is beyond giving medication and giving block. There is something else. We have to believe the patient, and we have to think beyond there is a strong biopsychosocial component. I request all the participants, there are more than 250 participants have joined, that they can send their question answer in the question answer box. We will take care of all the question answer at the end after 3 lectures. So we will move to the next lecture that by Dr. Lucas Rodriguez. And Dr. Lucas is again a good friend of palliative care community of the world. And he is going to speak how to use opioids for chronic pain. Dr. Lucas is chair of palliative medicine at University of Bonn since 2010, founding director of Department of Palliative Medicine at University Hospital Aachen 2003 to 2010, chair of Board of Directors of International Association of Hospice and Palliative Care since 2014, where he is working hard and trying to do a strong advocacy to develop palliative care concept all over the world. He was commissioner of Lancet Commission of Palliative Care from 2015 to 2017. His main research interests lie in the symptom assessment, opioid treatment, fatigue, cachexia, and ethical issues in palliative care. So here, Dr. Lucas will speak about how to use opioids in chronic pain. Lucas, you can share your slides and start, please. Thank you very much. Thank you for joining.
Thank you so much. Happy to do that, and happy about the invitation and the opportunity. I do have to say that, wait a second, get this started. Okay. That I do have no financial interest, but I spent large parts of my professional life advocating for better access to opioids for chronic pain, first in chronic pain management and the last years in palliative care. And the question is, why do we still have to advocate for that? Because actually opioids are one of the eldest medicines that mankind has used. So there are records of using this also for pain relief, not only for recreational use, for more than 5,000 years. And still the discussion is going on. This, for example, is a picture that most of you will recognize, a figure that came from the Lancet report on the lack of access to palliative care, the abyss on access, they called it, which shows the country size on a global map according to the amount of opioid used per head of the population. And this grossly misrepresents the actual size of the countries, as North America, Australia, and large parts of Western Europe are really oversized in this depiction, whereas the rest of the world, South America, Asia, Africa, are really nearly not recognizable because so little opioids are used globally. So we are saying that in these countries, people are suffering needlessly and they should access opioids more easily. On the other hand, we did have the news from the opioid crisis from the US and other North American countries in the last 4 years. showing how dangerous this is and resulting in a major rollback of the use of opioids in these countries, but also advocating globally for less access to opioids because this is such a dangerous substance which actually causes overdoses and overdose deaths in so many people. If you look carefully at the data, then actually most of the opioid crisis in the US comes from heroin or other illegal opioids, illegal fentanyl, for example, illicit opioids, and not from medically prescribed opioids, but still the discussion is on. And we have been, in the advocacy community on palliative care, we have been very busy to counteracting this narrative, saying that this may be actually a developed country problem, and this is not a developing country problem. We have been very focused on the WHO ensuring balance guideline, which says that basically, definitely governments have to pay attention that opioids are not misused, are not used for non-medical purposes, that there are reasons for drug control policy, but they also have an obligation to ensure availability of opioid analgesics for pain relief and substitution therapy. And I would like to add relief of breathlessness and some other symptoms as well. And they should be available, accessible, and affordable, and they are not in large parts of the world. That the opioids are not dangerous in itself, I can show you a rather short comparison between the US and Germany. We both have really high opioid dosages. The US says if you calculate the amount of opioids for the palliative care needs, then it's about 3,000% of what would be calculated. Germany has about half of that related to the palliative care needs, but still it's vastly over the need for palliative care. This is because parts of the opioids are used for chronic non-palliative care pain management, and which is very appropriate. And you can see that the US, the last data are available for 2015 for comparison, has about 33,000 overdose deaths, which is about 100 per million inhabitants. And the official statistic in Germany shows about 200, which is 2 per million inhabitants. So obviously, it's not only the use of opioids that's inherently dangerous. And as I said, probably in the majority of the world countries, the real problem is the lack of access. We did provide some data from the International Association for Hospice and Palliative Care when we did the opioid price watch, where we asked people, go to the next pharmacy next to your cancer treatment center and ask them whether they have opioids available. And if so, how much does it cost to pay for a 30-day amount that you can treat pain with in the average recommended daily dosage, and compare that to the standard worker wage. And then you find the red dots here are the pharmacies that said they do not stock opioids. So there's a large percentage globally in developing countries where the pharmacy says, well, actually, we don't have the opioid available. The green ones do have it available, but in some of the countries, for example, we have the example, one of the examples was from Mumbai. A worker with minimum workers' wage would have to save money for 40 days. His wage for 40 days would be needed to pay for 30 days of treatment. So he definitely would not be able to afford that. And we still do have a lot of misconceptions and myths about opioids. So this is something, just a short collection of citations from the last months and years. The general practitioner who says, I do not have the special prescription forms. The general practitioner says, I don't know how to do this. I'll send them to the oncologist. And then the oncologist tells me that he does not know how to prescribe opioids either. The misconcept that opioids are only for those imminently dying, and if you give them too early, then they won't work later on. You will become tolerant, which is not true. They work when you give it early, and they work for a long time. Patients who are afraid to get opioids, there is this kind of thing called opioid phobia, where patients say that, you know, this is if I take this, then I'm probably near death, so I'm not willing to take that. Or the nurse that takes every side effect as a complication of the opioid medication. So this happens quite frequently, that the nurses say the patient is so quiet now, and my usual answer would be yes, probably because he's not in pain anymore, and now he can sleep which he hasn't been able to do in the last days. Or the night nurse saying, you can't be in pain, you already had morphine, which is absolutely untrue, because in severe pain, you would need rescue medication, for example, with malignant pain, repeatedly, and you might need it a few times in the night. So what's the judicious use of opioid for chronic pain? And one thing definitely is for malignant pain. Ongoing chronic pain with cancer requires opioids. This has been confirmed by the WHO recommendations, which have been updated in 2019, 2020, and which say that in adults and adolescents, for the initiation, opioids should be used. This is one of the few recommendations that have been done evidence-based, and immediate release or slow release morphine should be used to maintain effective and safe pain relief. And in addition, you would need a rescue medication as required for breakthrough pain, but you would need around-the-clock continuous treatment with either immediate release or slow release morphine. So that's the area where I think there's absolute agreement. Much more difficult for non-malignant pain. There has been recent guidance from the CDC, from the US, which is really restrictive, saying that opioid for non-malignant pain should be used, well, best you don't use it at all. There are a bit more differentiated guidelines from Germany, which have been available from 2010 and have been updated in 2015 and 2020. And they really take a thorough look at the evidence and say that intermediate or long-term treatment, short, intermediate, or long-term treatment, long-term meaning more than 26 weeks, could be indicated for chronic osteoarthritis, diabetes polyneuropathy, postherpetic neuralgia, and low back pain. These are the 4 indications where you have good evidence from the literature, from long-term studies showing effects for more than half a year. There are some indications where you should not use opioids, such as primary headaches or functional somatic disorders with pain. There may be exceptional patients where you might want to have a therapeutic trial, but in general, these are contraindications. There are a number of other indications where opioid might be considered, again, rather as a therapeutic trial for the individual and not as a rule, like polyneuropathy, rheumatoid arthritis, restless legs, Parkinson's, or other chronic non-malignant pain with an individual indication. And the guidelines also highlight the risks of long-term treatment. You know, I've been in chronic pain management for a number of years, and initially we thought that opioids do not have any side effects in the long-term run. But by now we know that especially in older people, there is an increased number of falls, and that may lead to hospitalization or to other complications and even to deaths. So there is actually in the long-term studies an increased mortality with long-term treatment if you do not take this into account. There have been also reports about sexual dysfunction, endocrine dysfunction, and some isolated cases of respiratory dysfunction, but all of them for chronic pain patients probably are acceptable. And it's really the higher mortality from the falls which is the limiting factor. The German guidelines make it clear that for many chronic pain syndromes, the idea is that no single simple solution will be available, and opioids will not be that simple solution either. So they may be used as part of a multimodal pain treatment. And this is kind of a therapy regimen for the multimodal treatment from a German pain clinic, which goes on for 6 to 8 weeks, minimum of 3 weeks. And it's a half day or full day schedule with psychology, physiotherapy, education and counseling, but also sessions on medical treatment, which is one part of this really comprehensive biopsychosocial approach. And the opioids usually are only used to allow people to do physiotherapy or other therapeutic interventions with less pain for the time they're on this multimodal treatment. So the German guidelines actually say that for long-term, intermediate and long-term treatment, you should have some precautions like have trained staff for prescription and monitoring, check the appropriate indication, use it only in the context of holistic care and not as the single solution. Think about doing therapeutic trials. So if the patient does not have pain relief, take him off the opioid and see whether that makes any difference. If he has pain relief but not very well, you can also try to have a pause in the therapeutic regimen and see whether the pain increases again, because you have major placebo effects in the treatment of chronic pain. You should have strict monitoring and evaluation. I did have patients who had been treated elsewhere and said that they had been on an opioid for 1 year, even though the medication did not have any effect. And once they discontinued, they found they had less side effects. But I also had patients who had very good effect for several years. So I really would like to have strict monitoring and evaluation. And you should have safe storage and disposal. You should, for example, you should train the patients and counsel them how they should store their medication at home if they take it home. And you should certainly have mechanisms for taking back unused medication and storing at your faculty. As I said, for the vast majority of palliative care patients, but also a huge number of patients with chronic non-malignant pain, the real issue is the lack of access. And what we desperately need is WHO guidance for ensuring balance. That has to be updated, which is currently being done, but also finding simple models of prescribing and monitoring opioid usage for these patients. There is a number of good examples from India. Some of them from Kerala are well known. But this is an example from Africa, from Uganda, where they have nurse prescriptionists who are allowed to prescribe opioids and who are the ones who reach patients in the rural parts of the country. These patients would not see any doctor in their lifetime, but having nurse prescriptionists allows them to access opioid treatment if appropriate. And these nurses are really trained, as I said, in monitoring and evaluation, so they would also know which patients to treat with opioids and which not. With that, I end, and I'm really curious and looking forward to the discussion. Thank you very much.
Thank you, Lucas. It was a wonderful utilization of 15 minutes where you have said that opioids are required, but we have to use it judiciously by improving our knowledge and training. We will wait for the question and answers from the participants. And delegates, please send your questions from all the three speakers in question and answer box. We will move on to the third lecture of today's this session, and the lecture from the third lecture will be by Dr. Andrew S.C. Rice, again very good friend of whole of the world, who wants to know more about pain management, especially neuropathic pain management, and he is very good friend of all the pain physicians, those who are working and trying to develop pain management strategies in developing countries. Dr. Andrew is a clinical academic activity, active in clinical practice and translational research elucidating neuropathic pain. So mainly his area of interest is neuropathic pain. He's professor of pain research at Imperial College London. He is honorary consultant in pain medicine at Chelsea and Westminster Hospital, London. Andrew's research is on the neuropathic pain and covers both laboratory and clinical research, spanning animal models through deep profiling of patients with view to personalized medicine, to clinical trials and evidence synthesis by meta-analysis. His research emphasis is on neuropathic pain in context of infectious disease, HIV, especially HIV, herpes zoster, and leprosy, diabetic neuropathy, and peripheral nerve trauma, especially in military context. He has published more than 200 peer-reviewed papers. Whenever we want to search literature in the area of neuropathic pain, we will find a paper from Andrew. And that is his citation, and his citation index is 55. We can't even imagine. So Andrew, we are very honored and very proud of you, and we are very lucky that today you are here. And please go ahead with your lecture, update on diagnosis and assessment of neuropathic pain. Thank you, Andrew.
Thank you, Dr. Banik, and so much thank you for inviting me to talk here. My only regret is, can you hear me? Yes? Yeah.
Yes, we can hear you.
Good,
Yeah.
okay. So my only regret is that I'm not there in person. But actually, when I reflected on that, you would actually save me the excruciating pain as an England cricket fan of seeing the likes of Rickard Pant and Virat Kohli destroy the England bowling attack. But we'll pass on from that. So here are my disclosures. None are particularly relevant to this, this talk. What I'd like to talk about is perhaps unusually a bit for neuropathic pain, the assessment and diagnosis. How often neuropathic pain talks are mainly about treatment, but I'm going to concentrate much more on assessment. And this is the ISP definition of neuropathic pain, pain directly caused by a lesion or disease of the somatosensory system. It now has an ICD-11 code. And as Dr. Raja has already pointed out, it's distinct from nociceptive pain and also this new category of nociceptive pain, which essentially relates to sensitization conditions. And if we have this definition at the forefront of our mind the whole time when we're assessing a patient, then our diagnostic accuracy will be improved. So what are the key features of neuropathic pain? Well, it's pain occasionally generated in response to damage to the sensory nervous system. What do I mean by occasionally? It means that not every patient with a peripheral nerve injury or a peripheral neuropathy will get pain. In fact, the majority don't. Only 25% of diabetic neuropathies have pain. Only 10% of herpes zoster patients end up with postherpetic neuralgia. And understanding the risk factors for who and who doesn't develop neuropathic pain is one of the major questions facing research in this area. And it has three major flavors, shall we say, in which it appears. The spontaneous continuous pain, like the burning pain in the hands and feet of diabetic neuropathy that never goes away. Paroxysmal pains, of course, of which trigeminuralgia is the archetypal one, and evoked pain, which I'll say a little bit more about in a moment. But the point is that all of these can occur in either in isolation or in combination in any one patient. And it is important to assess them individually. And of course, you would score them differently. So paroxysmal pain is much more suitable for event diaries, like you would have, say, for epilepsy, than it is for a pain intensity scale, like in spontaneous continuous pain. The global prevalence is around 7 to 10%, predominantly driven by conditions like diabetic neuropathy. And it's variously associated with clinical symptoms and signs. And this is going to be one of the themes of my lectures, of sensory disturbance. And what's neglected, particularly in the preclinical literature, is the fact that it usually presents along with the symptom of numbness and the clinical sign of elevated sensory threshold, this so-called anesthesia dolorosa, or pain in the context of loss of sensation. And we often ignore that. And in fact, that's the much more common presentation. And of course, it's counterintuitive to both physician and patient. How can you feel pain where you're numb? Leprosy is one of the prime conditions where that's illustrated. And then there's rarer phenomena, but which are overrepresented in research related to gain of sensory function. And that can be gained in any sensory modality. So it might be paresthesia, or it might be allodynia or hyperalgesia, which I'm sure you're familiar with, or a much neglected sign, which is hyperpathia, pain in response to repetitive stimulation. So what are the questions we ask ourselves when we're faced by a patient who might have neuropathic pain? Well, the first thing at the top is to always have this definition, pain directly caused by a lesion or disease of the sensory nervous system, in the front of our minds. So the first question you have to ask is whether the patient has an underlying lesion or disease. You then have to ask, is there a neuropathy? So do they have diabetes? Do they have a diabetic neuropathy? Have they received chemotherapy? Do they have a chemotherapy-induced neuropathy?
And because without neuropathy, at least to my mind, you can't diagnose neuropathic pain. But as I've already intimated, not everybody with a diabetic neuropathy, for example, will have neuropathic pain. So you have to ask, having shown that there's a neuropathy, ask whether the pain is neuropathic, and then you can ask what the burden of the pain is. And I'll briefly come on to that at the end. So probably the most important aspect is the clinical context, so to be alert for the possibility of neuropathic pain. Trauma is certainly one, whether it's induced by a surgeon or artificially. And I'll say a few words about intercostiobrachial nerve trauma in mastectomy patients in a minute. Peripheral neuropathies, they're often length-dependent neuropathies and therefore have this classical glove and stocking distribution where predominantly the feet or hands are bilaterally affected the most. And if you see pain in this distribution, you should certainly be thinking that the patient might have a peripheral neuropathy. There are many neuropathies contributing to that. Diabetes is the most common one, antiretroviral, at least the older antiretroviral drugs, toxicity. But I suspect of most interest to you is a very common phenomenon about which we don't know enough at the moment, and that's chemotherapy-induced neuropathy, with particularly vinca alkaloids, taxols, and platinums contributing to that. And of course, many patients get it in the acute phase of their chemotherapy, and some persist to have it in the long term, and we don't know yet what the risk factors are for such persistent. As it was pointed out, infection is my major area of interest, and you will see some of these conditions in palliative care. We showed that these little donuts on the coat of the HIV virus can cause a toxic neuropathy. HIV neuropathy is now the single most disease quality of life changing condition seen in people living with HIV who are otherwise well. And a very similar situation exists in leprosy, with treated leprosy, but people left with residual nerve damage. And I've been privileged to work with many colleagues in India on that. And the archetypal infectious disease condition is post-pedic neuralgia. I won't say much about cold exposure or CNS disease, but tumors, of course, either compressing or invading neural structures will be extremely familiar with you. And this is a Pancoast tumor. And in fact, it was a single meeting with a single patient, and in the same week meeting Patrick Wall, that interested my career in neuropathic pain over 30 years ago, meeting one patient with a Pancoast tumor and talking about many of the features that Dr. Radbrush was talking about, the reaction of my colleagues. Compression neuropathies and rare genetic channelopathies are issues for another day. So what we came up with in the Neuropathic Pain Special Interest Group of ISP, and Dr. Roger contributed to this as well, was a diagnostic algorithm that fitted with the normal passage of a clinical consultation.
Anil Kumar of Trauma and Emergency, and many more.
Okay, and so pain is, obviously you have to have pain to enter this algorithm. That has to be the patient's complaint. I don't particularly like the word complaint, but presenting feature. And then you take a history. So is there a history of a relevant neurological disease or a lesion? Do they have a neuropathy? Is there imaging? Is there evidence of a neuropathy? And if you get the patient to draw where their pain is located, is it located in a neuroanatomically plausible location? I'll come on to what I mean by that. And if you have those factors, you can get to the level of possible neuropathic pain. What do we mean by is the pain neuropathic in a neuroanatomically plausible location? It means that it follows some kind of neuronal structure, neurological structure. For example, a single dermatome in herpes zoster, within a single peripheral nerve innervation, for example, sciatica, or intercostobrachial nerve damage in following mastectomy. Or this distal symmetrical picture that we would see, for example, in chemotherapy-induced neuropathy, where length-dependent neuropathies present themselves, usually small fiber neuropathies. So if you're seeing pain in these distribution, you should be alerted to the fact you might be dealing with neuropathic pain. And we don't specifically bring in symptom descriptors, but they can be quite useful. And I expect in the palliative care field, you'll be familiar with the Lanz scale. The one we prefer to use in my clinic and research is the DN4. the douleur neuropathique en quatre questions from France, my colleagues Didier Bohussera and Nadine Attal in France. Now, one of the things about questionnaires is that really I feel that they shouldn't be presented to patients unless you've shown a neuropathy, because then you can come up with a lot of false positives. But the reason we like this questionnaire, it's relatively simple, has 7 symptom questions which you can use alone, and 3 simple clinical examination questions which are relevant to the next phase. And if you get a score of more than 4 out of 10, there's a high probability that the pain is of neuropathic origin, has reasonable specificity and sensitivity, and it's available and validated in many languages for free download from the MAPI Trust. So this is I think the Hindi version we used in a study in Mumbai, and most of the languages in common usage in India are available. The other thing about the DN4 is that it's linked to a symptom inventory whereby called the neuropathic pain symptom inventory, where much the same questions are asked, but they're quantified. So you can monitor change, for example, in these parameters with a treatment intervention. So having got to the level of possible neuropathic pain, the normal clinical consultation would be that you examine a patient. And this is one of the things that I find myself teaching an awful lot, that I think many of us, sometimes we forget the importance of a physical examination. And if you can show pain in the sensory signs in the same distribution as the patient has pain, that gets you to the probable level of neuropathic pain. Mean by that? So this is about a focal sensory neurological examination, which really once we've practiced that, we can really do quite quickly, and to map the signs of sensory loss and sensory gain. Too often the neurological examination focuses on motor function and reflexes, and rather is quite light on the sensory aspects. And there's some quite good guidance on this. Here is a structured neurological examination that we use for research, but also for clinical purposes, that we published in an HIV manuscript. We find it quite useful, quite quick to do, particularly for us mere mortals like me who are not neurologists by training. And the other thing I would like to suggest to you is that quantitative sensory testing has a lot of mystique attached to it, but really it's nothing more than a sophisticated sensory examination. And my colleagues in Germany and the German Neuropathic Pain Network have really established a fantastic protocol for that, but it's very time consuming, very expensive, and requires a lot of training. And at the end of last year, they produced a cut down protocol that you can use for sensory testing with minimal equipment. And I would certainly advocate that for you. But what I would like to say about sensory profiles is that this is a study that we did with European colleagues, where we took neuropathic pain from many different etiologies. And the only exception to this pattern, actually, interestingly enough, is leprosy, and I'd be happy to tell you why that is. And what this tells us, that on the basis of the sensory profile, we can classify patients into one of 3 categories. The most common in 40% of neuropathic pain patients is this phenomenon of pain and sensory loss in blue here. But there are also less frequent red and yellow clusters that are characterized by sensory gain to either mechanical hyperalgesia or thermal hyperalgesia. So it's interesting from a mechanistic point of view that we can classify them this, and this was actually predicted in 1998 by Ralph Baron and Howard Fields and Michael Robotham, and their prediction is absolutely accurate. Why is this important? Because it may be able to guide us as to which treatments are most appropriate. So you would hypothesize that cluster 3, for example, would respond better to sodium channel antagonists. And there are some studies from Nadia Finnerup in Denmark that demonstrate that to be the case, although it's still this sort of sensory function-based prescribing is still very much in its infancy, and a lot more research is needed, but it's an interesting hypothesis. And one illustration of that is a paper we recently published with Eija Kelso in Finland, where we looked at patients who'd had mastectomy and had intercostal brachial nerve damage. And most of them fell into this blue or sensory loss group. And therefore you predict, for example, that sodium channel blockers would not be effective in those patients. To me, if you get to probable neuropathic pain, you can do that at the bedside, in the office. That is good enough for intervention in nearly all clinical purposes. Just a simple history and sensory examination. If you want to get to the definite level, you can do additional tests. For example, sensory nerve conduction studies to show you large fiber function, imaging, perhaps to show you a pancreas tumor or a stroke. And there are studies that take skin biopsies to look at intraepidermal nerve fiber density. But I would say for most clinical purposes, particularly in the palliative care setting, this is not generally necessary. And the final slide, I just want to talk about the burden of neuropathic pain. And this must be assessed, and we tend to, and certainly I don't need to remind this audience, that there's more to pain than just pain, if you like. Interference with sleep, mental health, quality of life, the impact on daily living. And this is, of course, a biopsychosocial model. And this has somewhat been neglected in neuropathic pain. It's much more prevalent in musculoskeletal conditions, particularly low back pain. And we need to think a little bit more about the burden of neuropathic pain. And one way we could illustrate this is perhaps some work we did with patients living with HIV. Again, I'm sure you meet some of these patients, but I think you could substitute HIV for cancer here, for example. And really their experiences fell into 4 major areas. Theme 1 is that neuropathic pain is complicated, the red theme. It's unusual. How can you feel pain where you're numb? And unless they see a specialist, sadly, still today, there's a lot of diagnostic uncertainty. And in fact, we find that a lot of the therapy in our clinic is just explaining the diagnostic procedure to patients, and that is often very reassuring to them, that they're not going slightly mad because they're feeling pain where they're numb or something like that. But then there are the interconnected other impacts of pain, which I briefly referred, the disruption to social environment, the vicious cycles on mood and daily functioning. And then, of course, you're laying pain on top, neuropathic pain on top of a disease, another disease, cancer, HIV, leprosy, diabetes, for example. And then I wasn't going to talk about treatment at all, but I think it's fair to say that the struggle for pain relief in neuropathic pain is still very much with us. We have low efficacy treatments or modest efficacy treatments with side effects, and we perhaps over-focus on drugs. So I think I'm going to leave it there, but only to remind you that the World Congress of Pain this year has gone virtual, and we will be having it over 6 days in June. And I hope to see you all there online. It's free if you're a member of ISP, free registration. Thank you very much for your attention.
Always so complex and always a challenge for a physician, and you have made it very simple in 15 minutes. I think most of the participants, those who are young and doing their PGs, I think they must have learned a lot from these 15 minutes. There are many questions on my mobile, but I will, because of the time, I will ask the 3 questions, right? We will start from Andrew. The one of the question which has been asked by, again, an MD student, that in intractable neuropathic pain, chemotherapy-induced neuralgia, and in these days we are struggling to give pain relief for a patient who is having severe diabetic neuropathy. So what works best? Because we are really struggling with this 10 years of old girl with the diabetic neuropathy, severe pain, and we have started opioids, and probably I'm not very happy that she's pain relieved. So what works best?
You're not alone in the challenge. You know, the neuropathic pain SIG, we produced some treatment guidelines based on evidence in 2015. They were published in Lancet Neurology. And the first line drugs would be tricyclic antidepressants, SNRIs, or drugs related to gabapentin. And there are some second line drugs that are particularly useful to topical conditions of lidocaine patches. And of course, amitriptyline is available on the WHO essential list. We got to try to make a case for gabapentin to be similarly available. That didn't succeed, but it is generically manufactured and a lot cheaper than it was a few years ago. That said, only 1 in 7 patients perhaps respond to 50% pain relief with these drugs. We still have uncertainties about the use of opioids in these conditions. So Dr. Lucas may be able to talk about that. But I think there's also a certain therapeutic benefit to explaining to the patient what their condition is and why they're feeling what they're feeling. And we should be paying more attention to the non-drug aspects of pain relief as well. So we've got some drugs, we perhaps over-focus on those drugs, and they're not that great. I wish I could be more optimistic. But the challenge you face is not alone. I don't know if Dr. Lucas or Dr. Raja have comments as well. They're both experienced in this area.
Thank you, Andrew. I know, I think this same thing and same experience we are facing with these patients. Lucas, can you answer this, that how safe the opioids are for these two group of patients?
Well, I can't answer it, but I think I share your concerns that, I mean, in a 10-year-old girl, you think about that you might have to treat that for the next 40, 50, 60 or 70 years. Are you really prepared to do that? And how safe will it be for that long period of time? It does work. So the other question is, do opioids work for neuropathic pain? And then actually, if you look at the evidence, their effectiveness is even slightly better than for nociceptive pain. Which is confirmed by people doing palliative care, saying if you have bone pain, or if you have from bone metastasis, or if you have from the soft tissue pain, then quite often you need non-steroidals, but opioids alone won't relieve the pain adequately, whereas with neuropathic pain, it often works well. Then the number needed to treat is not much better than what Andrew just said. So it's actually, I think, 2 something. So it's about 7. So about 1.5 out of 10 would benefit from that. But it would work. The question is, do you want to do that for the next decades of time? And quite often you would say, no, you don't want that. So again, I would recommend looking at the whole picture, doing a holistic approach, looking at any option for psychosocial treatment interventions like education, any relaxation treatment that you can think of, and anything else that's available apart from medicines.
Thank you, Lucas. Same thing we are doing. We have just relieved her acute pain and we are trying to educate her, and we are trying the TENS therapy and scrambler therapy probably will start working. Professor Raja, last question. Do you think that after your definition of pain, the scenario all over the world will change and people will move beyond needles and medication to talking to the patient and communicating well to the patient will make a lot of, this definition will make a difference?
Well, we certainly hope so. One of the things is that what we realized that these definitions help not only the physicians and healthcare providers, but it also, we've gone to educating patients and have patients understand that their pain is not purely just from biological reasons, and that it helps patients then describe the complexity of their experience to their healthcare provider. So what we hope is not only to help physicians understand that pain may be a complex phenomena, but hopefully it'll also help patients and patient organizations to promote this, and then that will facilitate their patients' discussions with their healthcare providers in terms of how they describe their complete pain experience.
Thank you, Professor Raja. How beautifully we have managed this 1 hour. We have taken 1 minute extra. You have done excellent. You have told everything which was required in this session. Thank you, Professor Raja. Thank you, Andrew, and thank you, Lucas, for giving your time. And I know very odd hours for Professor Raja, and for I think it's comfortable for Andrew and Lucas in the middle of the day. But thanks a lot, and thank you, audience, for giving they have sent a lot of questions, but I'm sorry we don't have time. Maybe if you really want to ask, please send it to me. I will send it to Dr. Raja, Professor Lucas, and Andrew, and they will answer your questions. Thank you very much. Thanks a lot.
Thank you, Sushma, for
Thank you.
Thank you, Sushma.
Thank you, Sushma Madam, for conducting the session so well. It was really enriching and wonderful. Now, and you have also stuck to the time. We will be moving to the next session, and the theme for the next session is kidney supportive care. And I'll just introduce the theme leader. He is Dr. Pankaj Sanghai. He is MBBS, MD Palliative Medicine, Assistant Professor, Department of Palliative Medicine, Supportive Care, Kasturba Medical College, Mahim, Manipal. And he's the winner of Bruce Davis Gold Medal, Travel Grant IHPC 2016. And he's also got Travel Award for MASCC 2019. And he's got special interest in renal supportive care, early palliative care. Over to you, Dr. Pankaj Singhai, for the introduction of the next team and speakers. Thank you.
So much, Dr. Rita and IAPCON organizers for giving 1 hour, one important hour for a very new subject in palliative care, that is kidney supportive care. It's a very new area, but it's a much felt need for palliative care, because we all know that these patients has a lot of palliative care needs. So we have 3 very experienced faculty who has worked in renal palliative care for years. We have Dr. Frank Brennan from Sydney, St. George Hospital, Sydney, who was in India last year for couples of years to teach basics of renal palliative care. He came in last IAPCON also, and he took some CMEs in Manipal, Mumbai, and Kochi. Sorry, Guwahati. So welcome, Dr. Brennan. We have Dr. Nandini Wala. She's senior palliative care physician. I think everyone in India know Dr. Nandini Wala. And all thanks to her for guiding me, especially for starting the palliative care from the beginning. Thank you, Dr. Wala, to join. And we have the renowned nephrologist, Dr. Amanda. She is from Sydney, St. George Hospital, Sydney. And she has her special interest, and she did a lot of research in supportive care in kidney patients. And she has her special interest in geriatrics nephrology issues in elderly patients. So a lot of research she did. Thank you, Dr. Amanda, for joining here. So we'll start our first session with Dr. Nandini Wala. She will talk to us about the research and symptom prevalence in chronic kidney diseases. Over to you, Dr. Wala.
Thank you, Dr. Pankaj. Thank you for the very kind introduction. Yes, it's my pleasure. I think this is the first time that we are having a session specifically, a whole session devoted to the renal supportive care. And I take this opportunity to just take us through the journey, how it happened to reach India and how it has progressed. And a small few outcomes within which I will also try to present some symptom prevalence study that we did in the center here in Mumbai. So let me begin. So as many other diseases, we are also one of the huge, we hold a huge population of patients with kidney disease. It's estimated, in 2002, it was 100 per million population, and later studies have shown 129 and 229 million per million population, which is a huge amount. It is so difficult to estimate because 90% of them remain undetected and they die untreated. And so whatever data that we can collect are from the remaining 10% who actually reach the healthcare services. And of these 10%, one of the studies which studied 10,000 of those on whom the renal replacement therapy was initiated, said that 40% of them were initiated, like dialysis was initiated as a emergency because their first visit happened to be in very late stages, and 60% of those patients who were on, started on dialysis were lost to follow up. So you see, it's a very, very difficult situation. So just to give you an idea about the requirement for renal supportive care in India, I look upon this particular paper by Dr. M. Sheikh on utilization costs and outcomes for patients receiving publicly funded hemodialysis in India, because there are many centers nowadays. So you can see here that out of he studied 13,000 odd patients, 2% ultimately underwent the real reason, that is real renal replacement therapy. 2% had it of this patient studied. The 64%, they stopped hemodialysis midway or just after the emergency aspect, and 17% are continuing on hemodialysis. Now we can see that 17% also died during the time of the study. We can see that these are the patients who would require renal supportive care. All those who reach the healthcare service for care, and also those who died, who might have benefited through the end of life care. And we should not forget the 90% who never reached the healthcare, and they are more likely to drift into a palliative care OPD, because that is where patients with a lot of illnesses ultimately reach in India. So this will be a huge value addition to our competencies if we are aware of how to handle patients with end-stage renal disease or even chronic kidney disease, because many of our other patients whom we regularly see also have some amount of renal disease. So with that, I'll just get into the story, and let me say that it begins with the generosity of spirit of Dr. Frank Brennan and attached to St. George Hospital, whom you will meet just in few minutes. And due to his generosity of spirit, whatever we could do in India has happened. Thank you so much, Dr. Frank. I request everyone to mute their audio, because this is a virtual platform and it becomes difficult otherwise. So it is also a story of serendipity. This happened in 2018 in 25th conference of IAPCON itself, where Dr. Frank was invited to a presentation. And that is where we met and we talked about it. And I never ever thought that, he will maintain touch and everything, but actually our email conversation continued, and we ended up creating something of an academic series for India. So, and this was also serendipity in the sense that this was also the time when Project ECO came into India, and we had this possibility of virtual learning. So Dr. Frank Brennan sitting in Sydney and we sitting in different parts of India, all of us could connect through the platform of Project ECO provided by Project ECO and have a series of topics. And these were presented as didactic as well as case discussions with key questions for discussion. So every session went on in a usual case presentation way. I would really request everyone to mute their phones.
Governor Asia Pacific chapter.
So this was another aspect of serendipity. This was also 2018 was the year when the International Society International Society of Nephrology also came up with this beautiful paper where they mentioned about comprehensive conservative care of the end-stage kidney disease as one of the treatment options, along with the renal replacement therapy. So you see so many things happen serendipitously, and I must say that it was time. They definitely mentioned that every patient who due to medical reasons cannot undergo renal replacement need to get comprehensive cancer care, conservative care, and those choice restricted, that means lots of patients, which I talked about, 90% of India, and those 64% who could not continue hemodialysis, they are called the choice restricted group. So all of them also fall into the renal, they really require comprehensive conservative care. So the need was there, and the competencies transfers were occurring. And this was also a big applause to the learners from India. So there were lots of practitioners who joined up in the Project ECO renal supportive care series, and we completed 8 sessions with 2 pre and post sessions. And in these you can see that from 2nd to 7th, we covered the major topics related to renal supportive care. The whole idea, the decision making around dialysis, symptom management, advanced care planning, as well as care of dying renal failure patient. And we also had 2 sessions integrated with very, very famous nephrologists. Dr. Mani is considered the father of nephrology in India. Dr. Mark Brown is the person with whom, the St. George Hospital, which represent Dr. Frank as well as Dr. Amanda. He's the one who joined up. Imagine the magnanimity of joining up to teach us who have been recently initiated to renal supportive care. And Dr. Vivekananda Jha, who is the current chairperson of the International Renal Society. So, there was collaboration. So Dr. Naveen had joined Manipal and he held the class. This was 2009 now. This is the 2nd year after our Project Eco video academic sessions. We had the master class, which was held. And so it is a story of collaboration and charismatic leadership. Dr. Naveen Salins, along with the management and nephrology department of KMC Manipal, organized this masterclass, where we had all the most major academic nephrology institutions of India represented. You can see some of them, and many palliative care faculty from across India came down. And the masterclass happened, and it was done in a systematic manner where we divided ourselves into groups where there was palliative care, nephrology in all the groups, and they all discussed the different topics together with the aim of coming out with some kind of recommendations contextual to India. So again, he has inspired all the audience through his beautiful, sensitive, and completely, down to the earth presentations. And he has inspired a number of participants from that meeting, as well as through his YouTube, through the Eco academic sessions. And in Mumbai, we had one meeting with the Mumbai Nephrology Group organized by Dr. Ashok Kriplani. And we also had, this nephrology unit. This is Dr. Tukaram Jamle. He's the head of the department in KEM Hospital in the nephrology department. And we had sessions with him. And now we are having the interaction with this unit. And so it is also the story of acceptance and dissemination of knowledge. And this was supported by Medical Humanities Division of KEM Hospital. Again, motivated volunteering, Dr. Lopa Mehta and Dr. Sunil Pandya. He's the ex-professor of neurosurgery, and Dr. Lopa Mehta is the ex-professor of anatomy, who both volunteered and made this happen through the medical humanities section. And I cannot thank enough the interns of KEM Hospital and Anita Satish, who's the specific volunteer for the renal supportive care. These are the people who actually did the IPOS intake, the small study that I'm planning to present today. So the initiative continued with the nephrology department. So this is the nephrology, the entire department. And when Dr. Frank Brennan visited us in 2020. So across 3 years, he has been coming to India, and each time he adds something new. And so some of the outcomes now. So one is the small study which I mentioned about, done in this government medical college hospital. So the study was about the symptom prevalence of patients. The patients were basically visiting the dialysis OPD. So they were already in stage 5, and this study was done in the waiting area of the dialysis OPD. The duration of study was very small. Unfortunately, this was started in late December. And by Jan end, the pandemic, and February, the pandemic set in, and we could not have this waiting area access. So that is the only time that we had this study on. And the data collection, as I mentioned, was through the students as well as the trained volunteer. And the tool we used was IPOS Renal patient version. And the main age group that we studied, we found that they're much younger than the other studies, which you will be hearing from others. Our patients are much younger. The males are very predominant in this group. Most of the patients were educated less than secondary school, and they were all in CKD stage 5D. And 89%, nearly 90% of them were receiving erythropoietin. And the frequency of dialysis varied depending on the accessibility of the center. So patients coming from far sometimes ended up having twice a week dialysis, and others were having thrice a week dialysis. So this is the IPOS renal plot that we used, the tool that we used to take this study. So this are some of the findings that we had. So regarding the I have categorized it in a little different way. So activities of daily living, poor appetite, difficulty in sleeping, fatigue, and mobility. These were all affected quite grossly. And what I'm trying to do is trying to see how it correlates to the Indian context after each of these graphs. So in poor appetite, some of the patients, when we talk more, a lot of it was due to the restrictions, and they lost their appetite because they had issue with taste, they had issue with the contents of the food, etc. So it was not just, so much more needs to be understood when patient just says, I have poor appetite. So we understood that it was much more than that. So taste related concerns, I don't want to go into details because there is an entire session on it. One important thing that we learned from Dr. Mani, the nephrologist, was that please do not stop tomato. It is one of the most important ingredients in Indian food. And it is not a culprit for progression of renal disease. The patient can continue, except when the potassium is something that we need to worry about. And also the one more thing that was emphasized was the protein intake that is allowed. Maximum is 0.8 grams per kg. And most Indian diets do not even meet this. So it is definitely not a good idea to stop dal and the pulses, etc. from the Indian food. The animal protein and milk, they're supposed to increase the hyperfiltration and adds the load of phosphorus and accelerates the decline in renal function. But the vegetable proteins seem to be relatively safer. So this is important to remember when we are advising regarding food content, because that could change the person's appetite. And Dr. Mani has recommended unrestricted intake of vegetable protein, because according to him, even with all that, we don't sometimes end up meeting the 0.8 grams per kg recommended diet. The difficulty in sleeping, I just wanted to mention how the renal disease affects the sympathetic tone, because we want an increased parasympathetic tone to allow sleep to happen. So reducing nighttime BP by careful titration of antihypertensives can improve the sleep and also reduce the risk of progression. So this is another point that, sitting in our OPD, and when patients come with a very high creatinine and they are not on any other nephrology care, there are a few things that we may be able to do to help them sleep better. Melatonin levels are usually significantly lower in ESRD patients. So this is one of the important tablets that we can use, which are relatively found to be safe, and we can start titrating up from 0.5 and can go up to 3 milligrams at night. So other sleep disorders need to be also looked for. And this is a topic by itself. I was just trying to talk in simple, important things that we can keep in mind based on the outcomes of the symptom prevalence. So when we asked them what have been their main concerns over the last week, many of them talked about the fluctuating BP. And the most important thing was, getting lost within the hospital, because it's a huge medical college hospital, and cramps and palsies because it was not featured in our list of questions. So physical concerns. So these restless legs, pain, and shortness of breath came top in the physical concerns in our study. And so just to compare it with the other studies which are done in India. So there had been a study on patients receiving hemodialysis for less than 5 years. And they used the 5 essential criteria of the International RLS Study Group. And they found that the prevalence was 10.3%, which was significant. And 25% of patients on dialysis when the criteria was met. So this is an important point to remember. And we need to diagnose. Our study showed a little higher incidence. And I'm not very sure that the essential criteria of the RLS study group were used, because although, when we train the volunteers, we are not supervising them during each intervention. So this is one important point we need to remember when we are looking at RLS. Is it really restless leg syndrome? So that is one part. Shortness of breath. The hemodialysis, although it may reduce the fluid overload, we may wonder, even when once the fluid overload is reduced, why should the patient continue to have shortness of breath? But patient may have multiple other coexisting issues in a kidney disease patient. It could be anemia, it could be COPD, it could be many other issues of pulmonary congestion or fibrosis or pulmonary hypertension. So there are other things we may need to rule out. Which will continue shortness of breath as an important symptom at presentation during dialysis, and in end-stage renal disease. So the emotional and practical concerns, patients were anxious, they were sad, they were not at peace. So many of these also have been studied by other researchers in India. So Shivam Gupta et al. Has published in 2018 that 82.14% of patients had depressive symptoms, and almost half of them had major depression using the DSM criteria. And another researcher has published that, again, it's very high figure, 71.3% and 84 according to baseline, second evaluation, and final visit. So it's a very high percentage of patients who have depression. And suicidal ideations were very, very high, especially on patients with hemodialysis, much, much more than conservative care. Another study by Pankaj Gadia, which was published in 2020, have shown that he has studied using HADS, anxiety depression scale, and he showed again very high percentage of patients with depression. And he showed that the anxiety is more in females, and depression also is much more in females than in males. And it is related to lower income, and it is related to type of family background. Like especially for India, we can see that anxiety in patients from joint family background is much less than patients from nuclear family background. And the duration of hemodialysis seems to be directly proportionate to as the duration of hemodialysis is longer, the depression and anxiety increased. So these were the few findings from India. And there was another study by Jha, Vivekananda Jha and Shashi Bhushan, which studied 130 CKD patients. But these are just CKD patients. 28 were on dialysis. You should remember that our data till now, what I presented was patients already on dialysis. They were attending the dialysis OPD. So they have seen that these CKD patients, these were the concerns: the pedal edema, anorexia, dyspnea, etc. And the Indian study of symptoms at presentation, the predominant symptom which was shown in the Putta Rajshekhar study was the gastrointestinal disturbance, breathlessness, fatigue, and urinary disturbance. You can see that the standard most common presentations in all these stages at presentation without dialysis, with dialysis, was breathlessness and fatigability. Others were, depending on which stage the patient was in. This was courtesy Amanda, who will be presenting today. So I just wanted to show that amongst her study, which was based on patients reaching renal supportive care in St. George Institute, compared with the existing literature. Here also, it was pain, shortness of breath, lack of energy, and poor appetite, nausea, vomiting. So this also is comparable to our findings, except that nausea, vomiting, we did not find it as significant. So I think this is the study part of it that I have. The waiting time, you can see how more than half a day the person, they really had a big complaint about the time that is lost in the visit to dialysis OPD. So that was one of the findings from the IPOS renal. Now continuing with the outcomes, I'm just continuing the story and finishing it off. So many other initiatives, like Pankaj has started a kidney supportive care in CMC, in KMC Manipal, and the renal supportive care group, they continued their dedicated academic teamwork. This is Group B, which worked around the decision making in around dialysis, and it has actually become a special edition in the Indian Journal of Palliative Care, which will be published by April. And of course, this is a session today in the Indian Association of Palliative Care Conference. And that's a great new initiative for India. And I definitely think it's an outcome of all the work that happened over the last 3 years. And thank you to the organizers for having this session. Other things are the stories of integration. So you can see the nephrology group in KEM, we sat together and created algorithms for each of the symptoms which are common in the kidney renal disease patients. So this is also going to be an appendix in the IJPC special edition. So the symptom management article has an appendix which has got the most common symptoms algorithms attached, whether it is pain or whether it is restless leg syndrome. So please make sure that you go through it and add value to your regular practice. It also is a story of new ways to think. So what are the departments? Must have had impact on the other departments. And I just look for what is the story going on in India as of today. And this particular presentation, this was a publication by Dr. Jayaraj, and he has talked about managing CKD without dialysis, a concept worth looking into. This is 2020. very recent, and another paper by Dr. Vivekananda Jha, which talks about global dialysis perspective and kidney transplantation for suitable subjects and conservative care for those deemed unsuitable for dialysis. So there are now voices within nephrology which are publishing and talking about supportive care. And also India has been included in the working group on the conservative kidney management in the International Society for Nephrology for strategic plan for integrated care. So this is another recognition of the work that we did for the last 3 years. This initiative is led by Dr. Sarah Davidson, assisted by Dr. Frank Brennan. So it's a story of commitment, of very much, we are very, very thankful and grateful to Dr. Frank Brennan for his repeated visits and each time adding value to what we do here. It's his love for India that has made it happen. And I truly value the mentoring and friendship. Thank you very much.
Thank you so much, Dr. Vallat, for taking us on the tour and the journey of the renal supportive care in India, the development of renal supportive care in India. You have presented what are the unnoticed symptom burden in these patients. And I'm sure this is only the iceberg of the patients who are coming to the hospital, who are coming to dialysis room. And there are many more who can't afford dialysis or who cannot come to the dialysis facility. So there is a lot of research need to be done about the symptom burden in a CKD patient. So we are a bit over the time, so I will quickly go to the next session. We will take question and answers in last, depending on the time, but we will surely take questions. Okay, so we'll move next to our next topic, how we can control some symptoms in CKD patients. Our invited faculty, Dr. Amanda, who is nephrologist working in St. George's Hospital, Sydney. Over to you, Dr. Amanda.
Thank you. As mentioned, my name's Amanda Siruwadana. I'm a nephrologist here in Sydney, and I'm also interested in various areas of research related to elderly patients with advanced chronic kidney disease. And I wanted to speak today about symptom control, specifically in dialysis patients, and the evidence that we have from a study that we've conducted about that question, can we actually make a difference? So as I mentioned, I work in Sydney, which is along the east coast of Australia, which is the biggest city in Australia. And it's within the state of New South Wales, which is a state with multiple other metropolitan centres, but also a number of regional and remote centres. And just before I go into specifically looking at symptom burden in dialysis patients, I wanted to touch on a little bit about the evolution of renal supportive care within New South Wales, the state of New South Wales, and really across Australia, in reference especially to what we've just heard about the evolution of renal supportive care in India. So certainly renal supportive care in New South Wales really originated from St. George Hospital, which is where Dr. Brennan, who'll be speaking shortly, is primarily based at. And it really stems from a number of questions that were asked in the 1990s and the early 2000s in regards to the burden and the, I guess, wave of the number of patients who are progressing to end-stage kidney disease in Australia, particularly the wave of elderly patients with a high rate of comorbidity, including cognitive impairment, cardiac dysfunction, and functional dependency and frailty. And there are increasing amounts of literature that show that those patients who are over the age of 80 with significant comorbidities, such as those that I've mentioned, that they are less likely and very unlikely to get a significant survival benefit from dialysis, but certainly do experience quite significant quality of life burdens from being on dialysis, which raises the question how we can best support these patients who are not going to benefit from dialysis. But also the third question, which still remains relevant today, is that there are a number of patients on dialysis that experience significant symptom burden, and how can we better support these patients? So in response to these questions, Professor Mark Brown, a nephrologist at St George Hospital in conjunction with Dr. Frank Brennan, started the Renal Supportive Care Clinic at St George Hospital in 2004 and really expanded the service and created an atmosphere for these kind of services really expanding across hospitals in Sydney and really across the state in New South Wales. And this was supported by also government funding to expand this model of care. Also supporting this was Australia and New Zealand guidelines on renal supportive care, as well as international guidelines that have provided guidance both on the model of renal supportive care for both dialysis and non-dialysis patients, but also specific symptom management guidelines. And then if we fast forward really to the fortunate position that we are in Australia in 2021, in New South Wales, with having several hospitals across Sydney, but across also regional New South Wales that provide renal supportive care services for both dialysis and non-dialysis patients. And most importantly, really run through a combined integration of both renal and palliative care services to provide renal supportive care. I would say, though, there still is a road to go on this evolution of renal supportive care in Australia, and certainly a recent survey conducted in the last few years among renal clinicians identified that 40% still do not have access to a renal supportive care service. So even in the setting of Australia, there is still a way to go. The question I really wanted to specifically look at briefly today was how can we better support symptomatic dialysis patients? And as Dr. Nandini has mentioned, we know that certainly dialysis patients experience a very extensive burden of symptoms, and it's probably underappreciated. The literature actually shows that nephrologists' perception of symptom burden is significantly lower than that of what patients self-report. So this is a summary of two key systematic reviews, one published in 2007 of 60 studies and another published in 2013 of 14 studies, which both looked at cross-sectional symptom prevalence. And as you can see, a very high burden of a number of physical symptoms, challenging physical symptoms, but also a very high burden of emotional symptoms, including depression and anxiety. And we know that these symptoms persist despite provision of adequate dialysis by all of our measures of dialysis, dialysis and electrolyte adequacy. Also, we know that symptom burden is a very strong predictor of reduced quality of life among dialysis patients, which raises that question of if we can modify symptom burden, what impact can we have upon quality of life? When we specifically look at the nature of these symptoms, some of them are very difficult symptoms to improve. For instance, lack of energy, poor appetite, which we've touched on, drowsiness. But also there are a number of symptoms which we now, on both an Australia-based but also an international basis, have a fairly evidence-based stepwise approach towards addressing some or approaching some of these symptoms in both dialysis and non-dialysis cohorts, including pain, shortness of breath, some of the gastrointestinal symptoms such as nausea and vomiting, as well as some of the skin symptoms such as itching and other changes in skin. So it's on this basis that the idea of renal supportive care for dialysis patients is really as a potential management adjunct to be used in conjunction with standard nephrology care and optimization of dialysis, but with the integration of specialist palliative care by way of symptom management. So a real focus on symptoms, quality of life, and the overall picture of patient well-being. The real approach towards symptom management through renal supportive care relies upon a form of symptom assessment to get a clear picture of true symptom burden from a patient perspective rather than from a nephrologist or from a perceived a burden of symptoms, to then institute targeted management approaches based on non-pharmacological and pharmacological approaches, but most importantly, providing longitudinal assessment and support for symptoms over time and across the trajectory of the dialysis patient's experience. Interestingly, despite renal supportive care services expanding quite significantly across Australia and also across the world, there hasn't actually been any prior literature looking at the effectiveness of renal supportive care specifically for dialysis patients, which is what we look to address in our study, which we published last year. So in this study, we were looking at patients across a period of 2010 to 2017 at St. George Hospital, who were a maintenance dialysis cohort who were referred to a renal supportive care clinic. And we were looking to quantify initially the symptom burden at baseline when they were referred to the clinic, and then the longitudinal trajectory of symptoms across their period in the renal supportive care clinic with the renal supportive care interventions. And also looking to see what factors predicted a response or a change in symptoms. So across this period between 2010 and 2017, at St. George Hospital, all dialysis patients receive an IPOS renal questionnaire, which we've presented with Dr. Nandini, which is a validated questionnaire used in advanced renal disease and also used in a number of other chronic disease states, but this has specific questions related to chronic renal failure with 15 physical symptoms and 2 emotional symptoms by way of anxiety and depression. It asks patients to recall their symptom experience over the 7 previous days and to rate the severity of these symptoms on a scale of 0 to 4, with 3 being severe, 4 being overwhelming. The routine practice at St. George Hospital over this period of time was that all patients who score either a 3 or a 4, so either severe or overwhelming on their symptom score, are automatically, on any symptom score, are automatically referred to the renal supportive care clinic in conjunction with their nephrologist being aware of this referral. Additionally, any nephrologist who felt that the overall symptom burden was high for a patient despite them not meeting that 3 or 4 criteria could be referred to the renal supportive care clinic, which is conducted away from the dialysis chair and utilises both a nephrology input as well as a palliative care specialist, as well as allied health with dietitian and social work support. So in the study, we included 127 patients over this period of time who were identified as having particularly high symptom burden on dialysis and who were referred to the renal supportive care clinic. And in comparison to some of the data that Dr. Nandini presented, our cohort, it certainly was a predominantly hospital hemodialysis cohort, but certainly a much older cohort who had been on dialysis for over 2 years on median, and with quite significant comorbidities of diabetes as well as ischemic heart disease. And this picture is fairly typical of the dialysis cohorts that we have here in Australia. Keeping in mind that this cohort of patients are those who were identified as being on dialysis with high symptom burden and then subsequently referred to the renal supportive care clinic, we do not unexpectedly have a very high symptom burden at baseline among this cohort, with a median of 9 symptoms experienced by patients and with over 4 symptoms experienced by 90% of patients. But interestingly, 10 or more symptoms experienced by nearly 50% of patients. And as you can see here, very high burdens of really most of the physical symptoms, particularly pain, shortness of breath, and poor mobility, but also very high prevalence of some of the emotional symptoms by way of anxiety and depression, which again, fairly comparable with what Dr. Nandini presented in regards to the Indian experience of dialysis symptom burden. When we compare the St. George data, which is in blue, relative to those 2 previous systematic reviews, again, interestingly, despite this being a somewhat select cohort referred to the clinic, they do have fairly comparable rates to what's described in the literature of all-comer dialysis patients, and really reflects that there is a high degree of symptom burden experienced across dialysis patients, and again, often underappreciated. And as you can see, though, among our cohort, the rates of anxiety and depression symptoms were significantly higher than that reported by all-comer dialysis patients. When we look specifically at symptom severity, as you can see in the orange, grey and yellow, that's the moderate, severe and overwhelming, a majority of the symptoms experienced were of these higher degrees of severity. So from there, when patients entered into the clinic, there is a stepwise approach towards individual symptom management. So it involves identifying the most troublesome and burdensome symptoms, approaching those symptoms first, and in a stepwise approach using both non-pharmacological and pharmacological approaches. And the duration of follow-up and the timing of follow-up was very much individualized, with some patients returning to the clinic after a fortnight or even earlier than that, and other patients returning just really as an as-needed basis across a period of time. So we looked to see what impact renal supportive care as a global intervention with its individual symptom aspects of management was having on total symptom burden. So we looked at patients, first of all, at 3 visits, the change in global symptom scores, as well as at last follow-up. And as you can see at baseline, the total physical symptom score was 15.8, which reduced down to 12.4 after 3 visits, which was a median of 3.1 months. And that there was a maintenance of this reduction in total symptom physical score across through to the last period of follow-up for patients during the 7 years of follow-up, with a median of 13 months for patients. Then when we looked at individual symptom scores, you can see that really across all of the symptoms, there was some degree of improvement and varying degrees as measured by the IPODS renal conducted serially, including some degree of improvement also for the emotional symptoms. And this probably indicates that there's quite a degree of interconnectedness of improving some symptoms having a secondary effect on other symptoms as well. In particular, and probably one of the most noteworthy things that we found from our study is that those patients who experience very severe symptoms, so the 5 most severe and overwhelming symptoms are listed here, they had the greatest magnitude of improvement across the course of 3 visits, which really highlights the role of integrated and systematic approach towards symptom management, particularly for those patients who are experiencing overwhelming symptom burden. We then looked to see whether there was any particular predictors of response. And one of the most noteworthy things across the period of follow-up of 3 visits is that we use certain measures of dialysis adequacy, which are urea-based measurements. And we were able to see that there weren't any significant changes in dialysis adequacy over the period of time, which leads us to say that there isn't really an explanation based on dialysis itself that's accounting for these symptom improvements. We also looked at baseline demographic characteristics and other dialysis-related characteristics and weren't able to identify any strong predictors of improvement in symptoms, but that in particular, those patients who had the highest symptom count or the highest symptom scores in terms of severity had the greatest benefit in symptom benefit, both in terms of global scores as well as individual scores. And I guess this isn't really the first study to look at interventions for dialysis patients. So this is, just briefly, this is a study that was published in 2006 that looked at 143 dialysis patients, hemodialysis patients, specifically looking at pain. And over 50% reported significant pain. 45 then it went on to an intervention phase where their pain was addressed depending on whether it was a nociceptive pain versus a neuropathic pain using different pain management algorithms. And they were reviewed periodically through a nephrologist as well as a nephrology nurse practitioner. And they were able to demonstrate that there was a reduction in pain across this period of follow-up, with mean pain score decreasing from 7.8 quite significantly down to 1.6. Similarly, this is another study that was published in 2013 that looked at 220 hemodialysis patients and looked at 3 specific symptoms: pain, erectile dysfunction, and depression. They had an initial observation period that varied in its duration, but found that there were no significant changes in the severity or prevalence of symptoms over this observation phase. And then when patients were randomized to either a nephrologist-based or a nurse-based treatment arm, where again, treatment algorithms were implemented for these specific symptoms, there was an improvement over 12 months along both arms compared with usual care. So what these studies highlight, that targeted interventions for symptoms result in an improvement in symptom burden. And similarly, what our study has shown is that by using a very integrated and systematic approach towards symptom management, that we can implement some kind of effective change in symptom burden in dialysis patients. So how does this inform our clinical practice? First of all, it reinforces just how high symptom burden is among dialysis patients and really raises that question of whether we should be routinely assessing this among all dialysis patients. Certainly the practice at St. George has been to do this for a long time, but it is only becoming a more routine aspect of dialysis care across Sydney and across Australia only in recent years. And our study really supports that there is a role for this in terms of identifying those patients with high symptom burden who are likely to benefit from a structured intervention program. It also, as I've mentioned, showed that renal supportive care as a systematic and structured approach does improve meaningful clinical outcomes, including overall symptom burden, but also some of those particularly troublesome and severe symptoms. What will be interesting in the future is looking at also what impact of targeted symptom management has, not just on symptom burden, but some of the other important clinical outcomes for patients, including quality of life, but potentially also time spent in hospital, unexpected hospitalizations, and ultimately also whether there is even an impact on survival, which are also other studies that we're looking at with this cohort of dialysis patients. So I'll probably leave it there in terms of my talk, but then if there are any questions or if we've got time, I'm happy to take any, certainly.
Thank you so much, Dr. Amanja, for taking us how we can treat these difficult symptoms and how integrating the renal supportive care or palliative care into the nephrology can make a difference in the lives of our patients. Definitely, I have seen the changes, and I've seen many researches and that you have brought out about integrating renal supportive care. So thank you, Dr. Amanja. Yeah. Next, we will go to our last session of renal palliative care by Dr. Frank Brennan, who is the master speaker, and he has done a lot of research, a lot of clinical work in this field. And so thank you so much, Dr. Brennan, for joining. Over to you, sir.
Look, perhaps just a couple of preliminary comments, and I'll move through the talk. Just to reflect on that history and really congratulate Dr. Nandini for her great leadership in this area and from the palliative care community in terms of initiating and moving and progressing renal supportive care in your country. And you can see just this remarkable story that's unfolded over just a few years, and also to acknowledge your work, Pankaj, there in Manipal as well, and other clinicians who I know are online. So I'm just going to focus on a particular symptom called taste, and taste has come up a little bit already in our discussion, particularly in terms of upper GIT symptoms. It's one of the most disabling and yet neglected symptoms of patients with CKD. Food, drink, and their enjoyment are significant nutritional, cultural, and social phenomenon. And each of my visits to India, I've just been struck by the enormous variety of food and the powerful cultural dimensions of food in your country. This is perhaps captured just by a couple of lines from Seamus Heaney, the great Irish poet, Oysters. Our shells clacked on the plates, my tongue was a filling estuary, my palate hung with starlight. The lack of taste or alteration in taste can be frustrating, debilitating, and have a profound impact on interest in food, nutritional status, mood, and quality of life. In this talk, I'm going to, and I'm very happy, Pankaj, just in terms of the strictness of time, for you just to raise your hand, and I'm happy to stop or summarize at that point because I'm conscious of timing here. Basic anatomy and physiology of taste, epidemiology, pathophysiology, and management strategies. So what's the normal story for taste? Well, taste can be usually summarized as salt, sweet, savory, or umami as it's called, sour and bitter. The human tongue has numerous papillae, and with the exception of the filiform papillae, all the others have taste buds on their surface. On the taste buds are a group of chemoreceptive taste receptor cells. There are three main taste cells. Type 1, salt, type 2, sweet, bitter, and umami, type 3, sour, and in certain circumstances, salt. And that's a pictorial representation of those three cells. The classic stimulants would be alkali metals stimulating salts like sodium, of course. Sweet or glucose goes to sweet. Glutamate, which is in meat and cheese, goes to savory. Caffeine goes to bitter, but also for the context of this talk, urea can set off a bitter taste. And acids go to sour. So acids could be acetic acid like vinegar or citric in fruits. Salt taste. This is to do with sodium channels, as you would imagine. Sweet taste is the strongest suppressor of other taste and is the most resistant to being suppressed itself. And this just has an adaptive advantage for us as human beings, taking in carbohydrates. Bitter taste, humans have a natural aversion to substances with a bitter taste, and it certainly warns us of potential exogenous and dietary toxins. And there's an evolutionary story here. And as I said, the urea causes a bitter taste. Remarkably, while the other tastes have one type of receptor each, in the human being, we have at least 25 different bitter receptors. Umami, a common example of umami is glutamate found in meat and mature cheese. Sour, as I said, citric acid in fruits and vinegar. So they're the main types of taste. I'm now just going to talk about saliva. So about 99% is water, but there's a combination of electrolytes and proteins. It's hypotonic and high in potassium and phosphorus and low in sodium and urea. And hold that in mind because there's a significant change that occurs with end-stage renal disease in terms of salivary composition. Saliva assists in the perception of taste, the solubilization, and the protection of taste receptors from damage. Zinc is important here too, because zinc plays an important role in the maturing, the maintenance and repair of taste buds. In addition to the individual taste cells, there's a lot of cell-to-cell transmission, and that ultimately comes up with a summation, if you like, in terms of the afferent nerve. This is a very busy slide, but just gives you an indication of how sophisticated this story is of positive and negative feedbacks to each cell, with eventual summation, as I said, into the afferent nerve that goes centrally. The interaction of different tastes. Well, in addition to activating individual taste receptors, stimuli have an effect on other tastes. So sweetness is the most suppressive of other tastes. And as you can see from this graph, sweet can start to completely suppress or significantly suppress other tastes. Other tastes can have a less effect on each other. There's a big story here in genetics, and that's been slowly unpacked. And say with umami or bitter taste, people can be hypotasters, less taste, normal tasters, and hypertasters can be extremely sensitive to certain taste. Taste, flavour and kinesthesis. Taste is a very complex sensation, as we've described, but flavour is the constellation of sensations, taste, smell and sensations of temperature and texture. And about 3/4 of flavour is produced by odorants. So these aromas come into the nose, the retronasal passage, the roof of the mouth, and eventually centrally. So that's where food eventually the flavour of food is felt. So practically, if it's to do with taste, we concentrate on taste. If it's flavour, it can have lots of different reasons for this person to have. There are also, in addition to taste, there's a wide variety of chemical compounds that act on the mucous membranes on the mouth to trigger sensations such as heat, cold, pungency, and irritation. So in the oral cavity, heat of chili, the irritation of wasabi, the cooling of menthol, and the astringency of tannins. And these are transmitted via the so-called chip channels. The language, scientifically, of course, agusia, absence, hypoagusia, reduced, dysgeusia, which is very common, and hyperagusia, exaggerated taste. Okay, let's now talk about CKD and taste alteration. This is a very common story. It's one of the greatest challenges is synthesizing the individual responses. A person could say, many people could say, I've got a taste change, but then of course they describe multiple different things. They may say it's metallic, it's acidic, it's bitter, or I've lost all my taste altogether. So it's a very subtle story of multiple different responses. Some people have food aversion, particularly to meat. Others have food cravings. And interestingly, in the studies, there's a high story of dry mouth. And these are the studies that have been done, some on CKD 4-5 and others on hemodialysis. You can see the xerostomia figures of the dry mouth, and also this extraordinary array of percentages in terms of bitter, salty, absent taste. Just going to very briefly just describe our service. Several years we've been asking patients, all patients who come to the clinic, about their alteration. And so over about 3 1/4 years, about 300 patients have asked this question. And it's almost exactly the same both for dialysis and the conservative group. About 40% reported an alteration in their taste. So this is a big story, isn't it? What was the severity of that? Well, 43% had slight severity, but 57% had moderate to overwhelming severity in terms of their changes. So that's a big story. What descriptors they use? Well, about half in our group said my taste is bland or absent, and then there was a smattering of other descriptors as well. Taste assessment tools. Well, they've got, for the general population, there are ones, certainly the visual analog scale. But interestingly, in the ones that the symptom inventory tools that we use customarily in renal supportive care, they don't mention taste. They talk about dry or sore mouth. So I think that this is quite a gap here, not a gap, but an absence. And we've been now adding taste changes to the bottom of the IPOS, helping that way. And indeed, for the CKD population, there's no validated instrument of taste assessment, so that work needs to be done. Why is there taste changes? Well, I think there's a couple of phenomena that's unfolding in terms of salivary flow, salivary pH, and salivary composition. Salivary flow, the evidence is mixed. Some say there's a reduced, others say there's no reduction in flow. Certainly with people with fluid overload or dehydration secondary to fluid restrictions and diuretics, this story can be important. And when body water content is reduced by 8%, salivary flow reduces almost to zero. And also this be particularly a story in dialysis as the fluid substantial body fluid levels fluctuations can occur. Changes in salivary pH. Well, normally saliva is slightly acidic, but in end-stage renal disease, it's more alkaline. And why is that? There are several reasons. The main reason is the increased concentration of salivary urea in CKD. Urea is broken down by oral bacteriureases into an ammonia, an alkali, and carbon dioxide, as you can see from this formula. Changes in salivary composition. Well, the studies consistently show that there's an increase in sodium, salivary sodium, potassium bicarbonate, and urea. And what happens there? Well, with higher sodium, you potentially may have salty taste. In high levels, it reduces sweet taste. Potassium, high potassium may set off metallic. Bicarbonate, unfortunately, causes loss of sour and umami. And urea, initially there's bitter, but there seems to be a sort of a biphasic story, and eventually it can start to reduce taste. So there's the summary of why of the salivary changes in CKD. People often have meat aversion, and this has been discussed a lot over the years. And as you can see from those studies at the bottom, food aversion can be universally reported as an aversion to meat. The inability to identify the savoury or umami taste can explain this. Several reasons. First of all, the concentration of salivary bicarbonate is inversely related to the ability to detect glutamate. Salivary bicarbonate reduces sodium ions, and that reduces the sodium ion concentration, and that decreases savoury perception. We've talked about the genetic variations in picking up savoury taste, and age. In some elderly patients suffer from a specific loss of umami taste with preservation of other tastes. How do we then manage? Well, just in terms of studies, there's very little, and the overall level of these studies in terms of evidence is very low. The only intervention that's been subject to randomized controlled trials is zinc. Zinc makes sense, doesn't it? Because zinc is part of the maturation repair of taste buds. It makes sense. 5 studies, RCTs, 3 of adults and 2 of children, mixed results. So it's not universally efficacious. And the Cochrane review of these studies show that the studies were not high, and that it was inconclusive in terms of demonstrating improvement. Mouthwashes. Now, this is interesting. Karen Manley, who's a leading researcher in this, she started to give mouthwashes to people with taste changes and looked at their taste and also upper GIT in patients with CKD. And virtually all of this group with taste changed there. So the water, salt, sodium bicarbonate, citric acid. And sodium bicarbonate produced the greatest improvement in taste, which was really interesting. And so that's become part of our work here, part of our treatment, sodium bicarbonate mouthwashes. It makes the saliva more alkaline, And interestingly, from a perspective of upper GIT symptoms, the higher the salivary pH, the less those symptoms. But I would say two things have unfolded here in the absence of studies, major studies. Number one, that renal dietitians have been working in this area for a long time, and they, over time, have really, over generations, have worked out certain techniques to advise patients, particularly in terms of food. But they're mainly empirical. And so all these things are sodium bicarbonate mouthwashes. So that can certainly be very helpful. But the other thing that's happened, and I found it fascinating, is that patients themselves do things. They gravitate away from things they don't like and towards food and drink that is going to stimulate more taste or help them. So I've learned a huge amount from my patients about this whole process and what they're doing, quite apart from any intervention. So people have a bitter taste, they gravitate to sweet food and drinks. Salty taste, they avoid salty foods. Absence of taste, they might start to have more things like chili or spices to stimulate a bit of taste. So whether it's based on professional advice or naturally reached, do these empirical approaches have a basis of underlying pathophysiology? For if they do, future management strategies may not be simply waiting, as we doctors often do, for the next medicine to come through. In fact, it may be carefully adapting the diet of the patient. The keyboard of taste. I think that there's a significant challenge here, and it may be useful to think of taste as keys on a piano. When a key is struck discordantly, another key can be introduced to counteract or moderate the original sound. A good example is bitterness. A bitter taste activated by raised salivary urea is highly discordant. So people start to use other keys like sweetness or sour to suppress the bitter note, interestingly. Another example is taste absence. Here it looks as though all major taste keys have appeared to be inactivated. So people, I think, move to minor keys like chili or spices activate, or cold, activating these other receptors that may help. Or they may respond with stronger stimuli of other major keys like acidic foods, drinks or condiments, sour taste or sweet tasting. Look, there's a significant amount of information to hold in mind, certainly in a short talk like this. Could information be brought into a simple tool? So over time, we've been developing this, the so-called CKD taste plate. On one page, a clinical tool to help clinicians. And this is it. So the inner circle of this plate are the descriptors, what people describe, bitter, metallic, salty. And the outer part of this plate are the advice, the clinical intervention, if you like, to say for salty, to avoid salt, to do this or to do that. And so this is helping us then bringing so much information into a relatively simple tool. So what steps would we do if we were going to use this tool? Well, first of all, screening, because we've got no validated symptom taste inventory, it's really just perhaps using the IAPCON or some other way. The patient, if reporting taste alteration, then the first thing to do is see if they've got any oropharyngeal lesions, because this may be the story and this needs a medical review. But if they don't, and you're assuming it's the CKD story, then starting to use the taste plate. Just to give an example, this is an 80-year-old woman on a conservative pathway. My taste is gone. So we go to the absent or bland taste part of the plate, and then looking at the outer circle there, what the advice are. And there are lots of different things, trial of cooking with spices, chili, vinegar, etc. In terms of sweet, we have to be careful with diabetes, but cooking, say, meat or chicken with some honey or something like that, a little bit of tomato, we've talked about tomato earlier, with some carbohydrate in it, incorporating acidic foods, etc., etc. So this is perhaps one example of using the plate. To what extent do these taste changes contribute to upper GIT symptoms? This is a fascinating story, to realise that there may be an effect, a cascade effect, if you like. It's not simply the taste, but how it's impacting there. So there's a complex interaction between taste alterations and upper GIT symptoms. Bitter taste can produce nausea, vomiting. Logically, of course, if you want to get rid of a toxin, and as a genetic basis, can also cause it actually causes gastroparesis, interestingly, bitter taste, slowing down noxious substances may be coming into the GIT. Nausea and vomiting and dry retching are not precipitated by those tastes. Nausea can be precipitated by significantly raised salivary sodium and that ratio. Salivary bicarbonate, less dry retching xerostomia. So these slides perhaps indicate that there is quite a story here in terms of taste and what unfolds here. Anorexia is an extremely complex symptom, and it's not simply taste. We cannot pretend that, but it's just interesting if there's an altered taste perception. And also, the dietary nutritionists tell us that taste alterations in CK are associated with poor indices of nutritional status, malnutrition, and increasing mortality. So while taste alterations are not the only cause, they do present. So perhaps this is interesting if we start to think about this. The taste alterations having a cascade effect in upper GIT symptoms, leading potentially to weight loss and malnutrition. Now, it is true, anorexia and nausea, early satiety have many other causes, but it's interesting if you have taste at the beginning, it may well set off that cascade. So the closer association, the emerging understanding, it may be that basic interventions may not only improve taste perception, but also upper GIT symptoms. I'll stop there because I'm conscious of time. Thank you. And once again, thank you for the invitation to speak. And I just congratulate the organisers for including renal supportive care in this virtual conference. And once again, a credit to Nandini and Pankaj for their leadership. Thank you.
Thank you so much, sir. I know that's it's a very vast topic, and we need to have a full class on this topic itself. But keeping in mind the topic and the time, I thought we will take some questions, but we have already overshoot almost 10 minutes, so we may not be able to take questions, but we will definitely answer it in the chat box. Just one question I would like to take from Dr. Amanda, because she is only nephrologist here. Well, just a quick question. So I wanted to ask, like, how nephrologists, what questions they have regarding palliative care, especially about withholding the dialysis or withdrawal from the dialysis. What do nephrologists perceive about this?
So I think certainly the role of palliative care for dialysis patients, certainly in now the unit that I work at, is so heavily reliant upon palliative care and upon renal supportive care, because there's a greater recognition, first of all, of just how burdensome some of these symptoms are and how challenging it can be to address them. And using a very much, I guess, a very different approach to what is our standard nephrology care, which is often focusing on numbers and parameters and really stepping back and looking at some of the complexities of individual symptoms and how interrelated they are, is certainly the huge, I think, challenge that nephrologists face and the need for integrating palliative care. I think the next aspect does relate to withdrawal of dialysis, which you've touched on, and which again is a very challenging thing for nephrologists. Initiating dialysis is often, significantly easier than withdrawing dialysis, and in the Australian setting, withdrawal of dialysis tends to come about in the setting of patients progressively deteriorating in terms of quality of life and function, and it often requires a long-term relationship with both a nephrologist but also a palliative care renal supportive care physician. And so I think increasingly for our frailer dialysis patients, introducing renal supportive care earlier to try and introduce palliative care and a long-lasting relationship with patients and families is how withdrawal of dialysis is becoming more facilitated in a way that's, I guess, less, challenging for nephrologists compared to, for instance, 5 or 10 years ago even.
Thank you, Dr. Amanda, for that. I feel integrating palliative care early, as we discussed in oncology, we should integrate it into the nephrology, in the dialysis room, in nephrology OPD as well. So I will conclude this session by thanking all our speakers, Dr. Nandini Wala, to taking a journey of palliative care in India and about the symptoms those are there in these patients, and Dr. Amanda to to teach us how we can integrate and what difference we can make in these patients and in the care of these patients. And Dr. Brennan, who took all effort to teach us the most common symptom I have seen in many patients. They have this persistent taste changes, and it's very difficult to treat as well. So thank you for teaching from the very basic, and I am a fan of your teaching methodology with 150 slides you covered in less than 10 minutes. That's thank you so much. Good night, sir. It's almost 11 o'clock in Australia. Thank you so much for staying late tonight.
Thank you,
Thank you,
Pachi.
Pankaj. Thank you.
Thank you for
Thank
sharing.
you.
Audience for joining. You can put questions as well.
We move on to the next session, which is about palliative nursing. Palliative and hospice care nurse provide care for those who are at the end of their lives. They are there for the final transition and use an entire array of medical knowledge and tools, skills, compassion, and life experiences to help in the best way they can. I would like to invite our theme leader for the session, Sister Hanife McCampbell. Sister Hanife is an oncology and palliative care nurse specialist and a public health nurse. She mentors and trains nurses in pediatric oncology and palliative care. She is an honorary head instructor and mentor for ELNEC India. She is an honorary consultant for Jeev Daya Foundation, CIPLA Palliative Care and Training, Trinita Society for Health Research for Children. She is a guest faculty for AIMS India for ELNEC, Tata Hospital Kolkata, and CIPLA Hospice and Training Center, DNIP Care IAPC. She also volunteers as a home care and OPD nurse, as well as taking care of children who need palliative care and children with special needs. So I invite Sister Hanife to chair the session.
Hello, everyone, and welcome to wonderful people that I have invited for this panel. Julia Downing is there. Hello, Julia, and Dr. Betty Farrell is. We are going to play Dr. Betty Farrell's presentation then. Dr. Betty Farrell has been in nursing for 43 years, and she has focused on her expertise in research and pain management. She is the Director of Nursing Research and Education and Professor at the City of Hope Medical College in California. And she has 450 publications in peer-reviewed journals. She is the principal investigator of the End of Life Nursing Education Consortium project, which we have been very lucky to start and expand in India with an enormous help from CIPLA Hospice and Palliative Care. And she directs many funded projects related to palliative care in the United States. In 2013, Dr. Betty Farrell was named one of the 30 visionaries in the field of American Academy of Hospice and Palliative Medicine. In 2019, she was elected a member of the National Academy of Medicine. And Dr. Betty Farrell was my teacher about 20 plus years ago in California, USA. So I'm very grateful that we will be able to hear Dr. Betty talk about nurses' impact on palliative care here.
Hello, I'm Betty Farrell, and I'm very glad to be a part of your wonderful meeting. And today will be sharing just briefly with you some thoughts about how nurses can lead and transform palliative care in education and research. As we all know, nurses around the world play a key role in palliative care. There's no other professional that spends more time at the bedside than the nurse. And nurses are involved with the patient's physical needs, psychological needs, social needs, and spiritual needs. Nurses are also very important members of the interdisciplinary team in palliative care. Our LNEC project, the End of Life Nursing Education Consortium project, began in the year 2000. Our first course was in the year 2001. And LNEC is a collaboration between my hospital, the City of Hope Medical Center, and the American Association of Colleges of Nursing. This slide lists the content that we teach to nurses around the world to support them in palliative care. We begin with a focus on what is palliative care, what should nurses know when they're caring for seriously ill patients, many who will die of their disease. And we also have modules on individual topics such as pain management, symptom management, ethical and cultural considerations, communication, loss, grief, and bereavement, and final hours. Our courses are train the trainer, meaning that nurses and others come to our programs to not only learn the content, but to also learn how they can teach it to others. So we have over 40,000 LNEC trainers, meaning people who are now prepared to teach others. These trainers have returned to their institutions and facilities and educated over 1.2 million clinicians around the world in good palliative care. In every state in the United States, and as of 2019, we reached our 100th country. The LNEC curriculum has been translated in 12 languages. We have several different curriculum in the LNEC project, our LNEC core, which is basic preparation, but we also have specific curriculum for geriatrics, pediatrics, critical care, advanced practice, oncology, an entire curriculum on communication, and we have training programs for all of the undergraduate and graduate programs in schools of nursing in the United States. Internationally, as I mentioned, we've reached 100 countries, and we're so excited about the incredible work that's happening in India as one of those countries, and also our translation into multiple languages, including current translation to Hindi. In all of our projects since the beginning 20 years ago, we try to evaluate outcomes. And so on our LNEC website, you will see a list of over 40 papers that have been published evaluating the impact of LNEC training. I just wanted to briefly give you some examples of where LNEC is being taught around the world, so you will know that nurses all around the globe are learning better palliative care. 13 countries in Africa have been taught through the LNEC curriculum, and some wonderful work happening there throughout the country, throughout all of these countries. A lot of work in Tanzania and Kenya, but many countries throughout Africa. Also in Asia, there's very extensive LNEC work happening in China, in Japan, in South Korea, the Philippines. These are some of the countries that are really training the most people, but we also have many countries sharing the LNEC curriculum and preparing nurses to be involved in palliative care. Japan has been one of our leading countries, and they've done an outstanding job of having nurses designated throughout the country of Japan as LNEC trainers. And in Japan alone, they have trained almost 40,000 clinicians throughout every part of the country in better palliative care. South Korea has also been a leader in teaching nurses in many areas, including geriatric care has been a major interest of the LNEC trainers there. In India, our first training there was in the year 2009. And we were so excited to be launching our efforts back then. And we continue to work very closely with many of the colleagues in India to provide education to clinicians throughout your country. In 2015, our LNEC core was adapted to be used by many nurse educators. And again, funding is continued with a focus on nursing schools as well as practicing clinicians. So we are so proud of the amazing work that's happening in India. And we know that you are really quickly becoming a model for the rest of the world because of your outstanding LNEC training throughout India. The Philippines has been another country doing a great amount of work in palliative care. As with many countries, they began with a focus on pain management, but now are training in all aspects of palliative care. Singapore has also been another key country with extensive LNIC training. And China began in the year 2015, focused first on oncology nurses in one of the cancer hospitals in China, but now extending into nursing schools and education throughout the country. Throughout Europe, there are many countries that have been a part of our LNIC training. Many of these are Eastern European countries, and we have repeated for about 15 years major training in these countries each year. We also have worked very closely with our colleagues in Romania, and they have developed a leadership center to help prepare not only nurses in palliative care, but those who can become leaders in this area of palliative nursing. So throughout all of these activities around the world, we've learned how important it is to have a standard curriculum, the LNIC curriculum, because that allows us to really raise the bar, raise the standard of care for everyone across countries. If across different regions, nurses are trained and really supporting the same standard in things like pain management, symptom management, communication strategies. If we're all working together to impact schools of nursing, both at an undergraduate level and for those countries that do have graduate level nursing education, then we can begin to see the field really advance, because we have established a standard of what seriously ill patients and their families need to receive from nurses and during their care in serious illness or at the time of death. This last slide just reminds us of, again, how important nurses are when it comes to serious illness care. The slide says that if someone you love is seriously ill, you would want their symptoms to be well managed. You would want support for your family, good communication, spiritual and psychosocial support, and you would want a death that respects and honors their life. So the same things that we wish if it was someone we loved are the same things we're trying to provide for all patients within countries such as India. And what this slide also says is that those things, having pain well controlled and good communication and good support, won't happen unless clinicians at the bedside are trained to provide that care. So on behalf of the entire LNIC project, we really want to just thank you. We know that India has a long history of leadership and commitment in areas such as pain management and hospice care. And now this is such an important time when India and other countries are trying to really extend the work of palliative care so that we can get this care started earlier in the course of illness and so that it can reach so many populations. In our work in LNIC, as I mentioned, we have separate curriculum, for example, for pediatrics, because we know that caring for children, there are many unique needs. We also have a lot of focus within our pediatric curriculum on infants. So infants that are in neonatal care or those who may have very serious illnesses and die shortly after death. So care of seriously ill children is a very important part of our curriculum. We also have really seen how important it is to be working with schools of nursing, because we all know that the best approach will be if our nursing students learn palliative care while they are still in their education programs, so that when they enter practice and they begin to work in hospitals or clinics or homes, that these nurses are starting their practice already having a basic knowledge about palliative care. And so here in the US and in many other countries, we've seen how important it is for palliative care to partner closely with schools of nursing so that we can really integrate palliative care well within schools of nursing. So I wish that I was able to be with you in person. Earlier this year, myself and one of our other LNEC trainers, Judy Pace, were planning on coming to India. And of course, that wasn't possible because of the pandemic. But we look forward to a time where we can come in person and meet many of you and see your amazing work. I just want to say how proud we are of all the incredible work that you're doing in India. You are so impressive the way that you're reaching out and teaching other nurses. And I know that you are already a role model for many other countries as they think about launching palliative care efforts. So we thank you for all of your hard work and efforts and all the excellent care that you're providing. And we so look forward to continuing to work with you, collaborate with you so that around the globe, we can all do a better job of improving palliative care. Thank you so much.
Thank you very much, Dr. Betty Farrell. We are doing the best we can with incredible support from Dr. Shushma and Cipla Palliative Care and all the wonderful nurses of AIMS and everywhere else in India. And now I would like to introduce to you Dr. Julia Downing, who has been my little, she really kind of fills my cup every time I listen to her. She makes me happy because no matter how famous and how wonderfully, specially educated and trained she is, she still always sounds like a pediatric nurse. And I love that. And that makes my day, that gives me hope. And I love her little stories she tells. And I love her polka dot skirt. And I love to listen to her. So I'm very happy that she's here. Dr. Julia Downing is the Chief Executive of the International Children's Palliative Care Network. And she's the professor in palliative care at Makerere University in Uganda. And she has extensive experience in global palliative care. And also she works with multiple NGOs. And she's the honorary senior fellow at the University of Edinburgh. And also she is one of the people who got the Making a Difference International Award for contributions of cancer care from ONS in 2015. And she was recognized as one of the 8 change agents in cancer care in a publication on women as change agents in oncology in 2016. And I think she makes many children smile all over the world. And today she's going to talk about how we can make a change, how we can make an impact as nurses through specialty palliative care, namely here, children's palliative care. Thank you, Dr. Julia Downing.
Thank you very much. And I'm so pleased to be here today. And I wish I was with you in India, but look forward to coming next year instead, I hope. So I'm really pleased to be talking about how nurses can lead and transform palliative care in practice and administration. And I'm going to talk about this sort of in a global palliative care context, thinking of us as palliative care nurses, both within the context of children's palliative care and for adult palliative care. And I think we have our colleague coming up in a minute who's going to talk more specifically about children's palliative care. So I believe, and I'm really passionate about nursing, and I believe that nurses are at the forefront of the integration of palliative care into all levels of healthcare, whether that's at the home, in a health centre, in a hospital. Nurses are key to ensuring that everybody who needs access to palliative care can have it. Although sadly, we are still far off in many places. But we are in a unique position to drive that change, to drive that leadership for palliative care. And we have opportunities to show leadership, to show diversity, to show innovation in shaping palliative care in India, in Africa, where I also work, and globally. We have that opportunity to make a difference. And looking at the recently published State of the World's Nursing Report, one of the things that the International Council of Nurses, the World Health Organization, and Nursing Now stated was that governments and all stakeholders need to strengthen nurse leadership for both current leaders, but also future leaders, to make sure that as nurses, we have an influential role in forming health policy, in decision-making, in clinical care, and contributing to the effectiveness of health and social care around the world. They go on to talk about the fact that leadership programs should be in place to nurture leadership development in young nurses. As some of us are getting older and progressing through our careers, we need to encourage leadership and innovation in young nurses. So this is a call from the World Health Organization, from the International Council of Nurses, to develop leadership. And within palliative care, as we've already heard from Betty Farrell, nurses often spearhead palliative care, particularly in places where there are not that many doctors, where there are not that many doctors trained in palliative care, in the rural setting. And nurses therefore have a pivotal role in shaping and developing palliative care. And if we think about universal health coverage and the call to leave nobody behind, then we have such a key role within clinical and administration leadership. And we need to ensure that the programs that we are developing, that we are leading, that we are promoting are affordable, that they're culturally appropriate, and that everyone, no matter how old or young, can access them. So we are key as nurses to the leadership and innovation in palliative care. We know that nurses are often more available than doctors, particularly in the rural settings, although that difference varies in different countries. So I was looking at the WHO data, and Monaco has the highest number of nurses and the highest number of doctors per 10,000 people. Cameroon has the lowest number of nurses and doctors for 10,000 people. In the UK, we have 81 nurses compared to 28 doctors. In India, it's about twice as many nurses as doctors. In Uganda, it's a bit of a range. Actually, that's slightly wrong, but in Uganda, it's a lot higher number of nurses than doctors. And what about specialists in palliative care around the world? What about specialist nurses in children's palliative care? How many of those are there? Are there enough of us? And clearly there are not, to continue to lead and develop palliative care. We know we have a key role as nurses, and I just began putting a list of some of the areas in which we as nurses work within the clinical context, but also within administration. We have key leadership roles in clinical care. We need to be demonstrating the best practice in palliative nursing. We need to be ensuring palliative care is integrated into all of the clinical care that we provide. But also very much linked to what Betty Farrell was saying is that we need to have that training and supervisory role. We need to be advocating for palliative care. We need to be advocating for the children who need palliative care, as well as being involved in research and monitoring and evaluation. So we have a big role. But the reality, as I've already mentioned, is that there are very few specialist palliative care nurses, even less when we're thinking about children's palliative care. Often patients present with late diagnosis. Many present with advanced disease. Over 80% in sub-Saharan Africa, or particularly in Uganda, will present with advanced disease. There's often a lack of treatment options available. And we also need to be getting that balance between not making palliative care so specialist that it becomes inaccessible, but at the same time recognizing the specialist skills that are needed. So there are challenges for us as nurses in promoting, integrating, developing, leading palliative care. For example, how do we recognize the complex needs of people requiring palliative care, of the children requiring palliative care, deliver palliative care that meets their needs and their families in the context of low resources, a lack of nurses, maybe a lack of specific training? And it's great to hear of the work of ELNEC. And there's also the EPIC training and many other trainings in palliative care. But for many people, there is a lack of access to such training. There is a high burden of disease, many people who need access to palliative care. And in many countries, there is still a lack of recognition of what palliative care actually is, and therefore a lack of appropriate policy. We need to think about different models of providing palliative care, different models in low resource settings to high resource settings, different models in different parts of the country, depending on the culture, depending on the health systems. We need to think about providing care within conflict settings. We need to think about how do we care for those who have seen others dying in a painful and undignified manner, and so have that fear and expectation. What about providing palliative care for children? Many people, many nurses fear providing palliative care for children. We know that we are working within the context of COVID-19 and other pandemics. And also, how can we, as nurses, be recognized as leaders within the field? How can we make sure that wherever there are key leaders on palliative care, nurses are there and at the table? When the WHO are talking about palliative care, are nurses there at the table? So being recognized, I think, as leaders is a challenge. But as nurses, we are able to be innovative, to be resourceful, to recognize our differences and our diversities, and to think outside of the box, to think of new ways of doing things. This is a colleague, Liz Gwither, who some of you might know, who said many years ago, South Africa may not be a resource-rich country, but as a result, we are extremely resourceful. And my experience of colleagues in India is that you are extremely resourceful, that you are innovative, that you are able to think outside of the box. So we did a little research study. This is in Uganda, looking at nursing and midwifery leadership. And it was a focus group discussions with nurses across the country. And it was really important to understand some of the characteristics of leadership that nurses found valuable. So for example, this was a nurse talking about a senior nurse in the hospital who said that she's interested in the people she leads. And if you're interested in the people you lead, when they perform, you say thank you. So about recognizing the value of the work that our colleagues do. Another nurse was talking about one of their senior nurses being empathetic and looking out for you and helping you to improve. And on the other side, some of the negative characteristics, this nurse at the bottom here, you work under tension, under fear, you see her and even get scared, yet she has come. So there is poor performance. So they're scared of their nursing leaders, and therefore that impacts on the way that they perform. Different perceptions of nursing impact on how we as nurses and midwives lead. There was a great sense, and I certainly feel this, of pride about being a nurse. But at the same time, there was this challenge that many of the nurses saw themselves as being inferior and having that inferiority complex. And we need to get over that in order to be leaders within the field. And something that really hits home with me, one of the nurses said, you talk to a nurse and she says, I am just a nurse. And we say, what do you mean by just a nurse? We are nurses and we have skills and knowledge and abilities that we can use. Linked to that was the importance of professionalism and culture, and how as a profession, we are developing. As nurses, we are developing. As palliative nurses, our profession is developing. And in terms of building leadership development, these were nurses from across Uganda, but also ranging from very senior to very junior nurses, talking about the need for everyone to be trained as a leader. Each one of us as a nurse has a role in leadership, whether we're working in the community, in a hospital, at the national level, or at the local level, and the importance of training to help us develop our leadership skills. So we then looked at issues around leadership development. And again, looking at the content, what do we need to learn as nursing leaders? And really important when you look at this list, it wasn't just about change management or leadership skills, but it's about clinical care. We need to be the best that we can within clinical care. It was about nursing administration. So developing ourselves as leaders across the board. In Uganda, we ran a palliative care leadership program. It started off specifically for nurses and then we expanded it. We've trained over 40 leadership fellows over a period of time. And when we undertook that evaluation, we found that there was long-lasting impact on the participants because we had put time into developing their leadership skills, whether they were clinicians or in education or administration. We were helping them and supporting them to be leaders within their field. We found that ongoing mentorship was key and important, and that they could encourage and mentor other nurses working within palliative care. We also found that many of them had been promoted and been given more leadership responsibility and had the skills and knowledge that they had acquired had been recognized. So education and training on leadership is key if, as nurses, we are going to transform palliative care through practice and administration. Leadership, clinical and administration nursing leadership in children's palliative care, in palliative care generally, is essential. We can demonstrate best practice in clinical nursing and leadership. We can show what a difference we can make as nurses. We can lead other nurses. We can be leaders within palliative care. We need to bring respect and recognition to the profession. I have been in places, and I'm sure many of you will be able to relate to this. I've been in places where as soon as people have heard I was a nurse, they've turned their backs on me. That's not good enough. We are standing up as our profession. We are standing up to gain the respect and recognition that as palliative care nurses we deserve, and we can get through our leadership. We can impact policy. We can make a big difference to the lives of those that we are caring for, both adults and children. And we need to look at how we make sure that clinical leadership is a career pathway, and that once you get to a certain level, you don't have to stop working in clinical practice. I have really enjoyed in this past year spending time in practice again as a nurse, helping to support work in COVID-19. But it's been really good for me to be able to put into practice what I hopefully teach. So just in closing, if we go back to the State of the World's Nursing Report, this was an interesting quote that they've been looking at studies. And this was actually about retention and retainment of nurses. But they said that the leadership styles of clinical managers, so that leadership styles of nurses in practice and organizational culture directly impact nurses' job satisfaction and turnover, and may affect quality of care. So we need to be developing our leadership styles. We need to be developing as clinical, as administrative leaders, so that we can impact the quality of care that all those adults and children needing palliative care can access. And something that I learned quite early on in my career was that if you want to do something in your life you've never had, you'll have to do something you've never done. You'll have to take that step. You'll have to move forward to try and bring about change. And Dame Cicely Saunders, who is often thought of just as a doctor, but was a nurse, a doctor, and a social worker, and a real role model to us within palliative nursing. And Dr. Robert Twycross said about her, "We too must not just talk the talk, but like her, we must walk the walk and stay the course and continue the task of changing the world." And as palliative nurses, I believe that we can continue the task of changing the world as we develop our leadership skills, as we move forward and develop palliative nursing around the world. And just as I close, in April, we will be launching this report to celebrate the work of palliative care nurses around the world. Thank you.
Thank you very much, Dr. Julia. And she said it in 15 minutes, in a nutshell. And the rest is ours to take over from here and carry it on, because we can make a change, we can be leaders, and we can think out of the box, even in India, because we have Jugaad. No, we can just fit in like the water and find our path, and we are doing our very best. We're trying. Thank you very, very much.
Thank you.
Our next panelist is Ratish Nair, who is the principal of nursing and chief nursing officer at AIMS Patna. He is the Commonwealth Professional Fellow of the Liverpool John Moores University. She is the Fellow of Royal Society of Public Health, and she's the secretary. He has been the secretary of Indian Nursing Council in Delhi, and he has been an assistant professor, associate professor, and now he is the principal of Patna Nursing and chief executive nursing officer of AIMS Patna. And one of the most impressive things about Ratish is that he still knows and cares and does patient care. He knows patients, he does patient care, he acts and talks and walks around like he's the staff nurse at AIMS Patna. He has been a volunteer for Dinip Care when he lived in Delhi. And one of the reasons why I had these panelists, and I included Ratish, is that these nurses, despite their degrees, despite their wonderful positions in their careers, they still are real nurses who actually do clinical practice, which makes me very proud to have them here. And here's Ratish going to talk about the challenges and more challenges and the rewards of leadership in administration, in palliative care in India.
Okay, I hope I'm audible. I will not be taking much of the time. There are a few points which I have noted down. One is, first and foremost, is sensitization, which I have found it a bit of a task when it comes to sensitizing policymakers, institutes, because palliative care as such, there is a confusion among the people who are not oriented with palliative care. One is either they identify palliative care with hospice or with pain management, and that's a problem which we face in the initial time. And for policymakers, unless they are sensitized about what exactly is palliative care and why we do it, or the real purpose of it, will not be able to move forward. And I'm one of those who benefited from the ELNA consortium. I have been a participant for ELNA, and that's how I came across or my introduction to palliative care. Before, otherwise, I'm a mental health person by background. My background is mental health person. So, and about palliative care as such, in India, we had many short-term programs which are running for nurses as well as for physicians. And about the nursing programs which you have found, it varies of duration or it varies of content. At the same time, what happens mainly in India is a very diverse country. It's a huge country. We cannot compare it with any other. I don't think maybe with US you can, but it's vastly varied in terms of health as well as healthcare facilities. Accessibility to health, it varies from state to state. One of the main problem is about having palliative care. I think we'll be able to know about how it varies from state to state, the availability of palliative care or the facility for palliative care. It's not very equitable, and if you go down south, you will find some of the organizations working in palliative care down south, which is some in Kerala and Tamil Nadu, but some of towards up north, even I think if you see the data, we'll be able to find out it is almost non-existent somewhere towards the eastern states or towards up north. So one of the problem is having regular or a moderated or uniform program which creates palliative care nurses. And why I'm saying this is because I have been a secretary for Indian Nursing Council. We get proposals for awarding credit hours for programs, and if we are able to award CNE credit hours for the candidates who are undergoing these programs, people will come forward and take up these programs for updating themselves, which is of a continuing nursing education. If that's the least we could do for it. Otherwise, the next is we could have like Dr. Julia Downing suggested, we have some nursing programs which could be created, which could award a post maybe a postgraduate diploma, or maybe if not a full master's degree program, but we could consider one of those. Even we had done some groundwork to start one at AIIMS Patna ourselves. So maybe that could be a role model for the rest of the country to start a program with. And another problem with creation of palliative care nurses, as we said, the healthcare facilities of India is divided there is a very clear-cut demarcation of private and public facilities available in India. And both the cases, the way healthcare is provided, or it is very different. So in case of public setting, I'm talking about, which we are part of, public, I mean the government setting, which I am part of. Why I'm saying is, you educate a palliative care nurse, but the palliative care nurse may not be available in the palliative unit unless we create specific positions for palliative care, rather than just call them as just nurses, because the palliative care nurse word need to be on papers in case of positions which are existent in the government or public setting. Then we'll be able to say. And we have mental health nurse or a pediatric nurse or a general nurse which is available. We have to have the nomenclature of a palliative care nurse in order to have at least an identity. Then we will talk about going forward further. Palliative care nurses, I think the ELNAC trained palliative care nurses, if we see, retaining palliative care nurses is a challenge for most of the institutes, retaining them to be in palliative care itself, the palliative care facility, or many of the times it happens there is a high turnover of palliative care nurses. So we find it very difficult for retaining them. We have to devise some ways of retaining them. One thing is, two of the people whom I know who were working in Delhi at the time exclusively in palliation, they just wanted to shift out of palliation. I asked them, they were very young, it's not like they have done their job, but they were very young. I asked them, why do you want to change it? Because it's not going to make much of a difference, and even the pay is also not going to be different. Then why do you want to change? So they said, at the end of the day, we are emotionally exhausted and there is no support from, and we have to have some, because palliative care nursing is different, it's tiring and it's exhausting, and people need to understand that many of the times the institute or the policymaker have to understand these things, and there has to have some sort of an emotional support or some kind of a support system for palliative care nurses, because it's not very easy to be in palliative care settings. So retaining palliative care nurses is a challenge for from the administrative point of view. And the next comes continuing education in case of palliative care nurses, where we have to have continuing nursing education program, which need to be available periodically for updating of all of them, whosoever is working in palliation, because as we have seen the previous speakers in these panels, we have seen many of the evidences coming up. So we need updations. Another thing about I think Dr. Julia as well as Dr. Betty was talking about. This is my last point on the challenges. We need palliative care nurses in leadership positions. Palliative care nurses need to be in leadership positions in order to have at least then somebody who knows about palliation will be, or palliative care nursing will be on the policy table to give their opinion or to give some contribution towards development of palliative care nursing in India. I think that's all about the points which I have. I'll be happy to take any questions if you have any. Thank you.
Okay, thank you, Ratish. We are, of course, running short of time, but there is one question to both of you. We would like to have an answer from Julia and from you, Ratish. How are we going to do this? They are saying, how are we going to bring, there is actually two questions. How are we going to bring the educated, the committed, the educated nurse to be more involved at the bedside? And how are we going to bring the palliative care nurse to the leadership? Any suggestions, any ideas? We need help.
I think that is one of, after you, Ratish.
Ratish.
Okay, I'm sorry. So one thing is about having a palliative care nurses association, maybe, which will be a good thing to say. One good thing to start, because you have to have an association. Unless if you are not being heard alone, maybe probably you are going to be heard in a group. So probably an association would be a good thing to start with. And the another thing is having, as I said earlier itself, having specific positions of palliative care nurses. We have to call on, the nomenclature has to be given that palliative care nurse. It is not just nurse or clinician or nurse clinician or nurse, but palliative care nurse. That nomenclature has to be used always whenever there is a reference to palliative care. So these are two things which I would like to add, and I'm very happy. I'll be happy to.
Thank you. That's great. And I think this is something that we need to be working on at different levels. So as has been said, in many places, there is no such thing as a palliative care nurse. We're not recognized by the nursing bodies. So that's one area. Also looking at leadership skills and training our nurses right from undergraduate training, right from their pre-registration training, beginning to develop leadership skills in them, and also helping them to feel that they've got something to say, to stand up and say. So some of these things we've had in many places around nurses perhaps feeling inferior or not speaking out. We need to try and get rid of some of that. So begin to change culture, which takes time. We need to be working at the national level with the nursing associations, with the Indian Association of Palliative Care, to really get nurses recognized at that higher level and policy level. And we need to be being role models and encouraging nurses and showing that we can do it. We can have nurses in these key positions. It's not going to happen overnight. And sadly, I think one of the questions, and it was that the senior nurses are often not involved in clinical practice. Sadly, our nursing career structure seems to be that you can go up within clinical, then you go to education or you go to research and you become an academic and you lose your clinical. So we need to be helping nurses to have these dual roles where they are not just doing education, but they're doing education and clinical practice, because that practice then informs their education. So trying to develop some of these roles, but it takes time. It's not going to happen overnight, but working at these different levels to develop and promote palliative nursing.
Thank you very, very much, both of you. By the way, whoever is listening to us, we just have good news that we are starting Indian Hospice and Palliative Care Nurses Association of India, and we are almost done with our registration and our policies. We are very proud, and I think doctors in India have been supportive, especially without Dr. Sushma's support. We couldn't even have begin to think about it. And Dr. Kamal from Jodhpur and people like Julia, Betty, and great examples like Ratish, they are on the move. We thank you all, and let's hope we all keep in touch and you keep us going. Thank you very, very much.
Thank you.
Being in our panel. Good night. Thank you.
Thank you, Sister Hanife. It is wonderful to hear about the Association of Palliative Care of Nurses in India. And that was a real wonderful session on nursing, which gave an insight about role of palliative care of nurses in India. Now, moving on to the next session, that is based on spirituality. I take the pleasure to introduce the theme leader, Dr. Vidya Vishwanath. She is Consultant Department of Palliative Medicine, Homi Bhabha Cancer Hospital and Research Center, Visakhapatnam, a unit of Tata Memorial Center, Mumbai. She has been Honorary Tutor, School of Medicine, Cardiff University. She is Mentor, Quality Improvement Initiative, Equip India, NCC Collaborative with Stanford Medicine. And she is also a faculty, Cancer Treatment Centers Training, Asia Pacific Hospice Palliative Care, APHN, Lian Foundation, AIMS India. And she is a faculty for Impact, Head Neck India. And at the same time, I also take this opportunity to introduce Dr. Nagesh Simha. I would like to acknowledge and thank him. And he is the Medical Director, Karunashray, who has been the key person behind the session of spirituality. Thank you, sir. And over to you, Vidya Madam, for conducting the session.
Good evening, and thank you very much, Rita, for that very kind introduction. As we're already running 5 minutes late, I don't want to waste a single minute in this session that we're going to have on spirituality. And spirituality is, as we know, recognized as an essential element of palliative care, but the word is almost entwined with Dr. Christina Puchalski. So she will be our first speaker today to tell us what is spirituality in palliative care, along with her experience of over 2 decades. Christina Puchalski is the founder and executive director of the George Washington University for Spirituality and Health. She is professor of medicine at the George Washington University in DC. She's a fellow of the American College of Physicians and the American Academy of Hospice and Palliative Medicine. The most important thing is most of us use her tool, the widely used spiritual history tool, the FICA tool, and that is Dr. Christina Puchalski's. She continues to break new ground in the understanding of integration of spiritual care in healthcare settings as an essential element of whole person care. And this has led to the development of interprofessional spiritual care education curriculum, or the ISPEC. Dr. Puchalski is the author of Time for Listening and Caring, In Care of the Seriously Ill and Dying. She is also a co-author of Making Healthcare Whole and the Oxford Textbook of Spirituality and Health. In 2018, she was named as one of the 30 visionaries in the field by the American Academy of Hospice and Palliative Medicine. We are indeed honored to have you here, Dr. Puchalski, and over to you. Thank you so much.
Thank you very much. I appreciate that lovely introduction, and it's nice to be here with all of you. And Dr. Simha, it's so nice to see you, as well as many of the other people I see a little bit. I don't see all of you, but I see some of you on the band above the video. So I was asked to join you to speak a little bit from my own sort of perspective of this field and how it got started. So I do just want to share a brief story that as a medical student really impacted me. And that was visiting for the first time in a hospice, in our local hospice, patients for a rotation, and meeting a person who had pancreatic cancer, I believe, and she was dying. And I did a spiritual history with her using that FICA tool. And she said she didn't have any meaning. She wasn't spiritual. She didn't have any meaning. And that sort of was the beginning of our conversation. I came back the next day to follow up with her. And she said that, in fact, reflecting that question had her reflect on meaning. And she found lots of places in her life where there was great meaning. And she proceeded to tell me all about those. And one of the things she said at the end is, I have this sense that you might be teaching other medical students, so please tell people not to wait till they're my age to start thinking about what gives them that really important meaning, that ultimate meaning as someone especially is facing their end of life. And that struck with me. And we had already developed an elective in spirituality and health. And that experience just solidified for me the need to pursue this further. And we know that suffering is a huge issue, not only certainly where I was in Washington, D.C. at that time with that patient, but all over the world. And it continues to be a huge element for us to face globally, not just in palliative care, but in general. And so at that time, back in the 90s, I got involved in developing education curricula. So we were funded by the John Templeton Foundation to do awards programs for medical schools and then residencies in primary care, family medicine, primary care, internal medicine, and psychiatry. And so trained many of the medical schools developed courses, which then became sort of the foundation for the spirituality and health courses here in the US, and a model for some places around the world as well. And we then, I started GWISH. We were founded exactly 20 years ago. We're celebrating our 20th anniversary. And yeah, it's exciting. Just met with our dean, our new dean, and she is amazing. It's our first female dean. She's a surgeon and she completely understands this area and is totally committed to it, which is very exciting after 20 years. So we're excited about being where we are today. But as a background, when we started, really we started with the courses in spirituality and health, and very quickly it became apparent to me that we need to start doing things in the clinical setting, and that we need to do more than educate. We need to start thinking about models. And so working very closely with my friend and collaborator, Dr. Betty Farrell, and if there are any nurses online, they will certainly know who Dr. Betty Farrell is. She's a globally recognized palliative care and hospice nurse. She's done research at the City of Hope Cancer Center, and is really one of the living legends in nursing in the United States, and mentors many people, myself included. So Betty and I started working early in the 2000s to develop guidelines and develop the first guidelines around spiritual care within palliative care. And that was a generalist specialist model. And we have since been working very closely with that model. So I think one of the distinguishing pieces of GWISH from other institutes that after us have started in the United States and in other places is that I felt very strongly that this is an area that every physician, every clinician should address. Spiritual distress it's a human right to have that addressed. We do not want to abandon people who are experiencing that. And yet, unlike pain management, which has its challenges, but it is not so easy for a person to talk about their own very deep spiritual distress. And so it's taken a long time to understand why that is important, and why that's important for not just palliative care, but across all of care. It's an essential domain of patient-centered care. Why it is so critical that doctors and nurses and other people on the healthcare team, other professionals, understand that that's equally important to physical, emotional, and social distress. And conversely, we also talk about spiritual health. What is spiritual health? and why that is an element, again, across all of care, not just in palliative care. But of course, what happens in palliative care is our patients are challenged with very serious problems, very serious illnesses, and are right up against the wall, so to speak, with facing their mortality. And so this becomes even more prevalent. Well, what happened last year? We had a pandemic. We have a pandemic, but it was horrible last year all over the world. And so for the first time, people began to understand what spiritual and existential distress is. When people are facing potential death, I mean, they're right up against what do I believe in? What is helping me? What's going to happen next if that's what they believe in? Or how do I make peace with myself, with my loved ones? When family members can't see their loved ones as they're dying, that is the utmost of spiritual distress. And so in many ways, the pandemic has shed a greater light on spiritual distress, and not to diminish the spiritual distress that everybody all over the world, and we're going through this globally too, all of us are going through this together, not to diminish that, but the questions that all of us have been asking in the midst of COVID are very similar to the questions that very seriously ill patients have been asking as they're facing their dying. And what gives me meaning? Do I need to be doing what I'm doing right now, or do I need to focus on other things? What is the most important right now in my life? So my patients who've had COVID, fortunately, many did not die, but a few of my colleagues, their parents died because they were in rehabs or other places where they unfortunately were exposed. The issues that they grappled with was, is this really the right place that I should be in? Many of my colleagues have retired or have gone on to different jobs. Many of my patients are rethinking their whole lives. And that is really, and they have to grapple with why is this happening to me? Why am I having to deal with all of this? And those are the types of spiritual questions that our patients are addressing. So I think what's happened in all of this work is, again, what is spirituality? And I know Nagesh and I have talked about this many times, because this IAPCON course that we're doing in different settings. And what's key is to understand that spirituality is broad. And the definition that we developed with Dr. Betty Farrell in California for the United States, and then later I did with many of my colleagues globally in Geneva, Switzerland, is that there's a common thread to spirituality that we need to understand. And that's that definition that it's about meaning, purpose, a search for meaning, purpose, and transcendence, however people understand that, and our connection to many things. Ultimately, the significant or sacred, again, how people understand that. So there may be cultural context, they may be personal context, there may be religious context. There's many different ways that people come to understand that, and that those can be expressed in beliefs and practices, and they can also impact decision-making and the way people want to be treated. So it's been a key element to try to think very broadly about that. We were asked to be advisors for an ad hoc advisory group for the World Health Organization Palliative Care Resolution. And I was very fortunate to be on the call when the resolution was worded, and advocated strongly for the word spiritual. And thank goodness to my friend Joan Marston, who was also on that call, who kept encouraging me when I mentioned spiritual, and there was a lot of resistance to that. She just said, keep at it. I keep talking about children, you keep talking about the spiritual. And that was really helpful to have so many colleagues that in that call understood the importance and were willing to have that written into the resolution. And furthermore, to have that resolution passed by the World Health Assembly. So that is a key piece, and would encourage all of you who are in palliative care to please use that resolution as a way to say, yes, we need to do this. We need to do interprofessional spiritual care. When we think about crises, and even in dying, so my students always say, you talk about spiritual, you talk about people who are dying can be healthy. Yes, they can be healthy in the sense of being at peace with what's going on, having their symptoms managed, but in being open to healing. And one of the questions I've been wrestling with, and we've all been wrestling with, I'm sure around the world, is healing, is transformation possible in the midst of a crisis? Or are we stuck in this crisis? And that's been a question that people have been grappling with. So that is also what patients grapple with. Can they find healing in the midst of serious illness and dying? And my answer to that is yes. You know, it may change from what they thought before they were ill or when they were younger or in another state, but that healing is possible, that finding fulfillment and meaning and purpose, finding joy is possible. And I think and finding hope. I think that those are the key elements. So when we think about spiritual distress, how does that happen? When you in distress, everything's chaotic. There's no grounding, and it's a very, very intense suffering that is hard to put words on. But healing can't happen right away, and healing is in that area is something that comes from the person themselves, but not alone, but with us as we accompany them in that process. And that's what's such a privilege for all of us here today as we reflect on the people we've accompanied, that we are not fixing them, but we're walking with them and saying, I'm here to help you find your own answer to that suffering. And it's an evolution of meaning over life. The models, which many of you may have already seen, we were part of a brief, developing a brief on spiritual care within COVID. And I'm happy to share that with you all, but it was, again, people from around the world contributed to this, and it was how do we provide spiritual care during COVID? But those similar guidelines are across all of care, and especially in palliative care. So the model is, how do we assess for spiritual distress? How do we assess for spiritual health? And thinking it in as that is our responsibility. And once we assess, what do we do with that? It's not just referring to a chaplain. There are things that each of us in our professions can do. Number one is presence and accompaniment. We can use discernment and questioning to try to see, is this spiritual distress? Is it depression? Who else should be on the team? But I strongly believe in working with board certified chaplains, or in many countries, they're now called spiritual care professionals. I understand that the training is different, and we're working very hard with my colleagues in trying to develop those programs around the world. And that's key. And so that completing a spiritual history is one aspect, but it's also being present and trying to not fix the person's distress, but to understand it better. I want to just conclude a little bit about IAPCON. So we're very excited. Dr. Betty Farrell and I have co-developed that course, Interprofessional Spiritual Care Education Curriculum. We've had a number of courses already. Our first one was 2018. We've done one in Perth. We did a virtual one last year. We have now developed an IAPCON with pediatrics, and Joan Marston is involved and very aware of that. We will be having our IAPCON course this year in October. Fingers crossed that we can do it in person, but very well likely we may be doing it virtually. So a component of that will be the pediatrics. So we have a separate, for the communication assessment and treatment plan, we'll have a separate section for the pediatric palliative care people. And then for the others will continue in the other group, but there's shared modules. So we're very excited about that. And we've also developed one for faith community leaders, looking at how our faith community leaders can be more involved in this type of care with their patients, particularly in the outpatient setting. So that one is extremely relevant, again, in countries where faith community leaders are the ones providing spiritual care. So that is a kind of a mini version of what their role is in working with people around spiritual distress. So we have an online course, as you probably, many of you know, not all of you know, but IAPCON is online, and it's 6 modules. It is available. We are in conversations with Dr. Simha and others on the call right now about how to do this in India. And one of the exciting things is, as we're working with other countries, is the cultural differences that we're making some modifications to say, this is what this case looks like here. What would it look like in your setting? And we're very excited to be doing that, as well as evaluation. I do want to sort of close with the challenge that we have of interweaving science and the sacred. And we always have to interweave that, again, in all of our work. And so the guidelines and the research are very important, and we have to do that research. But we should never have the research or the guidelines obscure the sacred. So our presence and our being with our patients is so key. And that involves our own commitment to this and our own sense of who we are internally and spiritually. So I think of my field as a physician, as a spiritual practice. Many nurses feel that way the same, as do chaplains, as do social workers, as do counselors. So to reframe a little bit and think what a privilege we have to practice this particular spiritual practice, which is caring for our patients. I would like to share a quote from Pope Francis, who is not only a leader for Catholics, but a global leader. And he's very much supportive of palliative care. And I've been an advisor on the Vatican's commissions on palliative care. And what he says is, you are called to care with delicacy and respect for the dignity and physical and psychical integrity of the person. You are called to listen with attention, to answer with suitable words that accompany the gestures of care, making them more human and therefore more effective. You are called to encourage, to console, to raise up, and to give hope. And I think that is something I so much relate to. And I think that is so much what I assume all of you, although I can't see everyone, I know that that's what you do. Thank you so much for your attention and your great work. And I look forward to more with you in the future.
So much, Dr. Puchalski. Those words were so beautiful, the way you concluded it. And another beautiful thing that you told us today was intervening science with the sacred. I think that's a key message from today. And thank you so much for your time, and thank you for telling us about ISEC and the training that we can hope to have in India. You told us so beautifully about spirituality. Now I would like to introduce Dr. Fiona Rawlinson, because she will tell us about how we can demystify spirituality and what are the challenges to teach students. Dr. Fiona studied medicine and zoology at Cambridge. She graduated in 1987, and it was a chance encounter that brought her into palliative medicine, and aren't we grateful for it? Medical education and palliative care education in particular has been her passion throughout her career. She has been course tutor for the Cardiff Diploma from 1998 to 2006. She has recorded over 30 podcasts and helped to set the University of Cape Town MPhil program. She has produced modules for Sub-Saharan Africa, and in 2015, she produced many modules in Cardiff and Karunashray Hospice too. And these are all freely available online, and they have been accessed in over 61 countries. In 2019, she has been adjunct faculty at MAHE, and currently she's co-training program director for Wales Palliative Medicine, reader in palliative medicine at Cardiff University, and program director for the Cardiff Postgraduate Palliative Medicine MSc Diploma and short course students. She works as a consultant in palliative medicine in Cardiff, developing innovative ways of supporting the ever-changing workforce's needs for palliative medicine. Education remains her top priority, while she keeps the patient at the heart of all medical education. For me, Fiona, you are a very dear teacher, like many of us here today. So really looking forward to hearing from you. Thank you.
Oh, thank you. Thank you, Vidya, and thank you to the organisers. I feel really privileged and honoured to be joining you, and I really wish I was with you in person, but this is definitely better than not being part of the story at all. But I'm reflecting just before I share my screen that really it's also a huge honour to be on a stage alongside such figures, Christina, as yourself, who I was with you in Bangalore, oh gosh, 5 or 6 years ago now at the colloquium. But the work on FICA and the work on actually demystifying spirituality for us to be able to incorporate into healthcare and palliative care has been so much part of my training. So this is just me saying to you, thank you for you and Betty and all the colleagues. But then I was thinking, right, well, what in my 15 minutes, how am I going to address the issues around education? And in the end, what I've done is just really to think about some of the challenges as we teach our students, as we teach our learners about spirituality. And I've pulled those together in just some, really bringing together my experience of teaching it, the things that have worked and the things that haven't worked, because it remains such a vital part of the palliative care curriculum. So what I'm hoping I'm going to do now is to share my screen, and Vidya, you are in my site. So are my slides sharing all right? Have I got a thumbs up? Are we good?
We are good, Fiona, we are good. Very
That's
good.
good. Fantastic. Okay. Right. So this is the one bit of educational theory which I think is really important when you're thinking about how you're going to teach a topic that's actually, as Christina has said, very broad and multifaceted. And Gagne and Briggs really defined the kind of the things that we need to do in learning, and that's translate facts, translate problem-solving skills into motor skills, into strategies for dealing with problems, and also around our behaviour. And if you simplify those, it comes into knowledge, skills, and attitudes. And those are three slightly different things, I think. But so when you're thinking about spirituality, we've got wonderful challenges, but they are challenges. Firstly, as Christina was explaining, actually, what is it? If it's a concept you've not really thought about before, how do you start thinking about it and working out how to explain it to somebody? Why is it important in health and palliative care? It's vital in health and palliative care, but can I explain to my hospital colleagues in surgery and intensive care, in all the other specialties, the role it plays? And what language can we use? How can we find the language? So that's the first challenge, I think. But of course, with the definitions that Christina was explaining and thinking about that interplay between religion and spirituality, in fact, yes, there are two separate things which for many people are closely intertwined. So there is the religion, our organized set, our specific set of organized beliefs, often in a group setting, but there's also then the spirituality, that sense of peace and purpose. Transcendence was a wonderful word that we've just heard. And spirituality is absolutely central to life, the meaning of life, and of course, the end of life, when life is ending. So it's quite useful, I think, when you're thinking about teaching, about designing teaching, using some of the tools that are there, to just be clear. We need to be clear in our minds what we're teaching, and in different cultures, different societies, different countries of the world, the role of religion as part of spirituality will change. For example, in the UK, the role of religion is possibly not quite so fundamental to spirituality as perhaps it might be in some of the African countries and in India. But unless you know the context where you're working, you might not know that. And so just understanding where it sits is really useful. And then, of course, it's immensely personal, spirituality. So the next challenge we've got is that diversity. It's a wonderful, unique diversity. That's what makes us human. But that means that there is diversity in our learners. There is great diversity in the patients and the families we look after. We have to ask each and every one each time. We can't assume it's the same for anybody we meet. It might change slightly day on day according to what sort of day it is. My sense of peace is different if it's the beautiful blue sky in Cardiff or if it's tipping with rain in Cardiff. My sense of purpose and life and well-being is ever so slightly different, but weather is definitely part of my being, and also diversity in society. So we've got some challenges. Then we need to think about the subject matter, and spirituality is not just about understanding the facts. As Christina was describing the evolution of Fika, it's about actually those skills. We might know a lot about spirituality, but we need to have the skills to be able to ask the questions. And so that's a really fundamental part of education. And I think that authenticity as a teacher is also really important, particularly for these sensitive topics in palliative care. So actually being aware of our own spirituality, being aware of how important it is for us, being in tune with it, will help us teach others the importance of that, so that it all really aligns. So there's lots of different slightly things we need to include. And then that takes, okay, so what have we got? And sometimes, like this year, we've not got very much of a choice. Virtual learning has been one of the great opportunities of the year, and online learning does a huge amount for people. But you could teach it in lectures, you could teach it in small groups, you could teach it as a one-to-one, you and a learner going alongside you and watching what you do. The wonderful concept of the flipped classroom, where you deliver some key facts to your learner group and they form an integral part of the education session. But when teaching spirituality, thinking of the challenges we've talked about, we need to think about the learner group. We need to think, what level are they at? We need to think, is it a one professional group or is it mixed? Is it an interprofessional team, like Julia was talking about in the previous nursing session? Or is it a group of social workers or doctors or spiritual leaders? Is it a lay group? Are you talking about spirituality perhaps to a community? So all of these things will have a slightly different slant on how you do it. So lectures are wonderful things. Lectures will allow you to deliver facts about spirituality to a large group all at the same time. So it's consistent delivery of that knowledge. It's a little bit dependent on the lecturer. It's sometimes you have to be quite clever to make a lecture interactive. And it can be in a lecture a little bit hard to check people's attitudes and people's skills. You can do a role play demonstration in a lecture theatre with lots of people watching, but it may not be as interactive as in a smaller group. But there's no doubt that a lecture would give you some facts about spirituality. So the knowledge domain, a lecture will be very effective at. Online learning, I'm really excited to hear about the online modules from Christina, and we'll certainly be looking at those. Online learning takes that lecture style to a different level, because online you can bring together hundreds, sometimes thousands of people together. So really get messages out there. So again, it's really good for knowledge. It's much more flexible, so people can learn at their own speed, at their own time, in their own place of work. You can, with careful questioning, you can do quite a lot around attitudes, and you can ask people to describe their skills. Unless you've got a particular online platform, it's more difficult to observe people using their skills, and they do need really careful design. They need to be interactive, they need not to use too much different media, as we found when we were designing the online courses for Indian palliative care. But they are a very efficient and effective way of really getting a lot of information to a lot of people. And with, as I say, with some careful questioning, you can think about attitudes as well. Small groups, when you can have them, are fantastic. So small groups, you can do knowledge, you can do communication skills, really role-playing, asking those questions, which until you've asked them a few times, don't necessarily come very easily. So that's why the tools such as the Fika tool has been so helpful in helping us to frame questions when we're not feeling quite so confident about the words that we're using, or a little bit shy perhaps. But also small groups, you can celebrate and demonstrate diversity in the learner group. People come at it from slightly different directions and will have interesting feedback. So small groups are a really great way, when we're allowed to be in small groups, of teaching spirituality. I enjoy them enormously. You get a lot back. There's all sorts of reflection you can do, but you do need careful facilitation, particularly if you're doing role play. You need a very safe environment in which to do role play. You need to train your trainers. And obviously, if you're doing small groups within a larger group, you're going to need either a lot of trainers or to repeat the same small group. So it's a little bit labor intensive, but it can be very effective for a global approach, really, to spirituality. One-to-one is even more amazing because you've got somebody with you and you can talk and you can see patients and families and you can reflect and you can talk. Lots and lots of opportunity. It's time intensive as an educator. You might need to repeat it a lot of times, and you do need to be able to give effective feedback. That's a really crucial element of the small groups and the one-to-one learning. But it can be a really profound way, and I would encourage people who are going to really make spirituality a big part of their professional world, perhaps do additional time as a spiritual support worker. The one-to-one reflection is really important. The flipped classroom approach, as I described, is wonderful. You can get information out to your learners before the session, but it does depend on that learner interacting with the material ahead of the session. And that requires quite a lot of input from your course team. And at the moment, with coronavirus having been such a difficult time, people haven't necessarily got the time to do that. Going back to attitudes though, that hidden curriculum of any of our palliative care education is really important. And I think as we're encouraging people to disseminate learning, that's why that bit of self-awareness and self-reflection is so important. What messages are we as educators giving to the group that we're with? It's an integral part of the hidden curriculum of palliative care. Interestingly, when I asked our Year 2 students in Cardiff last year what they liked to teach, out of 60 people, 45-ish loved doing pain control and nausea and vomiting and cancer. And a few people quite liked communication skills, and 1 or 2 liked spirituality, but they didn't feel at ease teaching it. And so we had quite an interesting discussion about why that was and what would make it a little bit easier. And the final bit of education is thinking about how do you assess your learners' progress on spiritual issues? And again, it needs to go back to what do you want to assess? And so is it knowledge? Is it knowledge about assessment tools, about the role, about meaning? Those sort of things can be quite good if you want to do multiple choice questions or computer marked questions. Skills and attitudes are a little bit more difficult to assess using multiple choice and computer marked questions. And believe me, I've written quite a number in my time. Case-based learning is really valuable. Written exams using reflective practice and case-based learning can be useful. Some kind of reflective practice on a patient and family encounter can be really useful, so that you're really looking at all of those things, the knowledge, the skills, and the attitudes. And I think this is really an instance where reflective practice is fundamental to our ongoing spiritual awakening as healthcare practitioners, as palliative care practitioners. It's central. It's part of our own lifelong journey, as well as that of our patients. And our patients and our families have been and always will be our greatest teachers. So I'm going to finish there, and at the end of the session, I'll be very glad to take questions. But once again, thank you so much for inviting me to be part of this panel.
Thank you so much, Fiona, for telling us about the hidden curriculum and how we're going to unmask that. It sounds so easy when we listen to it, but I still think we have a lot of challenges when we actually teach spirituality. So I look forward to hearing more from you about it once we finish with Seema's session, which is next. So now it is my absolute pleasure to introduce Dr. Seema Rao. She is going to tell us about the challenges in offering spiritual care in the COVID era, the Manipal experience. Dr. Seema Rao is a postgraduate in psychiatry, and we have been partners in palliative care since 2013, doing all our courses together. Seema graduated, she did her MSc, and she graduated with a distinction. She has been a senior research fellow at Tata Memorial Center for 5 years, after which she has joined Manipal, and she's a senior consultant at Manipal Hospital. And she is a key person in the CTC program. She is very well known in the IAPC group, and more importantly, she is a doctor by profession and a writer and a poet by choice. So looking forward to hearing you, Seema.
Thank you, Vidya. I hope I am audible. Apologies if there is any interruption in the connections. I'm apologizing right ahead. I hope it is not there. And it is a pleasure and privilege to be speaking after Christina Kuhalki and Fiona, who are my teachers. So thank you, and I'm very honored to be here today.
Fiona, would you like to tell us about how exactly we will be able to integrate, training healthcare professionals in a multicultural country like India?
Oh, well, I'm not sure that I'm completely the right person to do that, but I think a simple way to do it is actually to use a case. And to use a case as an example and bring together in groups, bring together your learners in groups, but have some very clear ground rules for those group sessions, just so that there is that element of respect for diversity and respect for that uniqueness of the person in front of you. But I think in such a wonderfully diverse country, I think creating the atmosphere that we are curious about each other's spirituality, about each other's groups, about each other's religion. But I think centering on a case helps to focus people on the need within healthcare. And I think that's often in challenging situations, I think often that's the key to start, but also to keep an open mind and to reflect on each session so that you can then wonder, right, well, next time when I teach this, I might do it in a slightly different way. I think that's probably where I'd start. It's a wonderful challenge, but it is a challenge.
And also with the numbers of patients that we see every day, sometimes I wonder if we are able to do justice at all to what. I can see Dr. Matthews there. Ma'am, with all your experience, would you like to throw some light on how we address spiritual challenges? I don't know if ma'am can hear me, but otherwise, Fiona, please.
Yeah.
I think just the other thing to add, just thinking about it, Vidya, is what you were saying about time. And I think sometimes we feel we have to address everything all the time with our patients. And actually in very busy world, sometimes you literally haven't got time. As far as I know, there are still only 24 hours a day, even though I'd quite like there to be at least 40. But knowing if you're somebody who can see patients again and again, you can address spirituality on some of those meetings. You can have it in the back of your mind, but you could have a scoping question, just generally how are things with you, but not necessarily go into it each time you're with the patient. And I think sometimes, although it doesn't feel comfortable, being practical and pragmatic, that's the way to do it. But we have to always ensure it's somewhere on the agenda. And if you don't talk about it in 1 or 2 sessions, then you do talk about it the next, or you hand on to colleagues. I talked a lot about pain today, but actually we didn't talk about spirituality today. But I agree. I think that's also a challenge.
It is. Seema, would you like to start? Or Fiona, could you just tell us, there was just one more question which is part of what we wanted to ask. It was about research in spirituality. I mean, we always talk about evidence-based and work in palliative medicine, but what about the research aspect?
I think this is really important, and I'm on the call with Dr. Simha, whose research has been in spirituality, as indeed Christina's. But I think it's an example of where some of the more social science approaches to research, those qualitative research techniques, which really allow you to explore in depth the sort of themes that people might come up with. I think that then, well, it's helped Christina to develop the FICA tool. But we need, I think, to do a little bit more on the importance for somebody's person health. So that person health within palliative care, we need to get the message out there to our colleagues who might not quite understand how important it is. So the impact of attending to spiritual care, that lovely interweaving science and the sacred phrase which you picked up, I think it's really important, but I think the social sciences approach may be more effective at exploring some of those issues.
And I can just see, thank you, Fiona. I can see a message from Marianne ma'am saying that we need to develop a tool for India. And another message from Moira, which talks about the Pali-COVID and how they developed it and how Seema has been part of it. So Seema, would you like to start?
Yes, Vidya, very sorry. I was not able to screen share from my side. I've sent the
We finish the Q&A first, and then we come to your session.
Yes, I'm extremely sorry for this.
Yeah, thank you.
Yeah, thank you. So, okay. Yeah, so as I was saying, what I will be talking is giving a brief overview of spiritual care in the COVID era, specifically with what our experience has been in Manipal. Next slide, please. Yeah, so the world needs an inquiry so as to learn as many lessons as possible. So COVID-19 has taught us and continues to teach us many lessons. Okay, we have learned to live with uncertainty. We have an heightened awareness of our sense of mortality. Our sense of safety is lost, and we are trying to cope. We are trying to cope with the suffering, with the distress that we see all around. Next slide, please. Studies have shown that spirituality helps us to adjust to adverse life events. Spirituality helps us to find a meaning and purpose in that suffering, as well as helps us to remain connected with what is very important to us and what we value most, and also with transcendent or with God. It is an integral component of quality of life, and it also enhances our emotional as well as physical well-being. And of course, spiritual care is an important domain in palliative and end-of-life care. Next slide, please. Given that this has been a global crisis, it's just one acute disease that has disrupted several aspects of the society: health, economy, social security, environment, and led to immense suffering. But this different regions have experienced this disruption in differently. So what I say today, or what I discuss today, it might be generalizable, but majority of it, or most part of it, might be from a very localized experience. Next slide. So we are a 2,000 bedded teaching hospital in the temple town of Udupi. We are a referral hospital for patients with serious COVID illness. Till February 2021, we had about 1,688 patients with 226 COVID-related hospital deaths. And only 53 of these were referred to palliative care. So our experience with spiritual care stems from handling these patients and their relatives. Next slide, please. Coming to this, I would like to discuss this small case study of this Miss J, who was a 70-year-old widow with critical COVID illness, who was dying in the ICU. She had a 25-year-old daughter who was diagnosed with COVID and was in home quarantine. The son was abroad. The lockdown restrictions prevented relatives from reaching them. The house was in a containment zone, so the neighbors also could not come for help. And I think this is a very common scenario that we see all over India when the patient is transported to a hospital, the families are quarantined at home, and coordination of care becomes very difficult. We had a teleconsultation with the daughter and son to discuss end-of-life care issues with this patient. The family was extremely distressed. There was repeated requests by the family to keep her on life support until she tests negative. Next slide, please. As we started exploring her spiritual concern, what came out was a lot of guilt in the daughter. Was I responsible for my mother's disease? Will I be responsible for my mother's death? Is the family going to blame me for getting the COVID home? Along with that, the distress of not being able to be there at her mother's bedside to care for her. And also the decline was very rapid. From diagnosis to end of life was just 10 days. And the family did not have enough time to grieve or to even accept this disease itself. And along with all other issues of why me, the lack of social support, the abandonment that they felt, the stigma associated with the being identified as COVID positive, one of the most important concern that stood out was what would happen to my mother after she dies. Would all rituals and rites that are normally followed be followed? Who is going to take her to the burial ground? Because the son was abroad, she couldn't move out of her house. How were we going to make this happen? This was a major source of distress. When we looked at the FICA tool, as we keep mentioning, what stood out was a strong religious belief and a ritualistic which was behavior which was very important for this family. Following religious rituals gave them a sense of collective purpose and identity. And they were also, the mother and daughter also were part of a larger religious community prayer group, which had been disrupted due to the COVID. So our spiritual care would need to address all these concerns. Next slide, please. So as Dr. Christina Puhalki mentioned in what we looked in a previous talk, what we looked at is therapeutic communication. That is art of accompanying the patient through their suffering, being compassionate, providing a safe holding place for the family, a place where they could express their guilt, their shame, their anguish without being judged. Reflective listening, as we call it, and also a place where we could explore the values, preferences of the patient and the family. This was what we looked at doing. But what was the challenge that we faced here? The study that we did showed that the duration of stay from referral to palliative care to death was 4 days. So we had to explore multiple things within the short period of time. Second, teleconsultation. We had to communicate with the family over the phone or the video, and that through its own challenges, where face-to-face interaction is not there, expression, and non-verbal cues can be easily missed. Now, therapeutic touch is a very powerful tool for expressing sympathy and compassion. We are bereft of it here when we use telecommunication. And what we say, meaningful silences, where we allow the family to express their emotions in silence, can become very awkward when it is in the virtual space. And finally, we have to depend upon the tone of our voice and the choice of words to convey empathy and compassion. And technical glitches, what we saw just now at the beginning of my lecture, is a norm. Most of the time in rural places, the internet connectivity is very poor. So the conversations get broken and this becomes very difficult. Second, as we looked at identifying the strengths of the family, rituals, prayer, and being part of the spiritual group or the religious community gave them peace and relief. And as we tried to reconnect the family back to that, what we noticed was there was stigma. Okay, it was not possible to find appropriate resources to give them the support. And this was during the initial periods of the lockdown, where the fear was very high and the virtual world was not as accessible. So this led to a lot of difficulty and helplessness for us also. as we tried to find out the details about what the after death care are, what the dead body management protocols are, as far as cremation or burial was concerned, these protocols kept changing with new information coming in, newer guidelines were introduced. So providing accurate information for the grieving family was difficult. How did we navigate this? There were two things that we did. We kept up the conversation, however difficult, through the net. The second thing what we did was we liaised with the district administration, which had appointed certain voluntary organizations that could look after the burial and cremation of such families. And this was also, we tried to connect the family with them so that they could, they belong to the same. We made sure that these voluntary organizations and the patient belong to the same community, so they could address their spiritual religious needs. Having said that, this was about addressing the spiritual concerns of the caregiver. The story of the patients is also not very different. Next slide, please. I would like to discuss this about Mr. S, who was aged 28 years, a young adult with metastatic osteosarcoma. He was well aware of the terminal nature of his disease, and the previous consult, we have had discussions about his preferred place of death, preferred place of care, whom he would like to have around him at the time of his death. His main distress and one unaddressed area was that he was unable to initiate conversations with his girlfriend about the seriousness of his illness, and we were planning to take it forward. Admitted for some symptom control, he was incidentally tested positive for COVID and had to be shifted into isolation. This created a lot of distress within him and for his family and for us as care providers also. Next slide, please. The two main concerns here that stood out was, one, will I die alone? He developed acute panic attacks, somatic symptoms of anxiety, inability to sleep. There was profound anger at the treating team as well as with his parents, primarily to this triggered by the thought that I don't want to die alone. The second aspect that troubled him more was death without closure. Peace is an important piece, and saying adequate goodbyes are important aspects of end-of-life care, especially for a dying patient. Having to be in isolation with this emotional disturbance, it was very difficult for us to initiate these conversations with his girlfriend. So this led to difficulties. The challenges that we faced here was, there was a lot of overlap between psychological issues, between spiritual issues, as well as physical symptoms here. So for one person working with a depleted workforce in a place of low resources, it was very difficult to manage multiple issues together. In addition, the COVID protocols ensured that the work team was depleted, the social workers were not around as much, and coordinated interdisciplinary management was very difficult. And as usual, the communication was primarily through phone, and the difficulties in communication applied here too. One difficult aspect was, as I accompanied him through the journey, it was very difficult to establish and maintain those professional boundaries. Our own individual vulnerabilities come out, and sometimes we tend to get affected by what we see. So this was one of the most difficult challenges at this time. Next slide, please. As we move on, we are COVID warriors, as everybody tells us, but we also get wounded. The blurring of boundaries, the thoughts that will I be the person in that place, or will someone I love be in that place, is something that will increases the fear and distress and spiritual concerns within us. I have seen a lot of healthcare workers experiencing a sort of a moral distress when they had to triage patients into care. As a palliative care provider, I look at end-of-life care as a care that is offered at home, surrounded by family and friends, where the patient's life tasks are completed, and there is closure, and symptoms are well controlled. Providing this in COVID situation was extremely difficult. Most of our patients died in the ICU alone, and the families were grieving away at their homes. Along with that, the isolation and anxiety you experience, the bereavement, personal bereavements that add on to your problems, all go on to add on to your spiritual distress. This is when self-care is extremely important at this time, because in addition to helping our patients and their caregivers, it is extremely important that we look inward and look after our spiritual journey also at this point in time. Next slide, please. So what did we learn from this experience? What we learned is spiritual care is a necessity. It is not a choice or a luxury. Everybody needs it, whether it is patients, whether it is caregivers or healthcare providers, we all need it. Our needs have to be addressed throughout. It is not that, at every point, it is important for us to be part of this spiritual journey. And it is also what stood out was none of us are trained adequately to provide this type of care. We perform multiple roles as palliative care physicians, as sometimes as psychologists, as counselors, and also we attempt to provide spiritual care. So improving our education, our training and research is extremely important. It is time that we looked at spiritual care as an important component of palliative care also. And at this time of crisis, it is important to have innovative measures. Like we need to look after ourselves and we have to look after our patients and their families also. And self-care is an integral part of spiritual care. So it is important for us to start that journey within ourselves, as also at a, do not wait till the end to begin that journey. Only when we are well versed with our own aspects of spirituality will we be able to accompany our patients in their journey. Thank you.
Thank you, Seema. That was a really poignant presentation. And I think many of us could relate to it. And in the interest of time and respecting time, I think we will have to close the session. Thank you very, very much, IAPCON 2021 and all the organizers. Thank you, Dr. Simha, for putting all this together. Thank you so much, Dr. Christina. Fiona, thanks for being there, as always. And Seema, thank you. I can see Sushma ma'am, Lulu ma'am, and so many of us over here I would have loved to ask from the Indian perspective, how we manage and what we do, but I think we have to move on to our next session. And thank you very much for this opportunity.
Thank you, Vidya, for an awesome session. I knew that you would be able to handle it extremely well. And of course, to Christina and to Fiona, they are not only your teachers, they are my teachers too. Because Fiona was my first tutor long back, 21 years ago. Okay, so it's been an awesome experience, and I'm so happy that the session went off extremely well. So cheers to everybody. God bless, and thank you.